I want to talk a little bit about AAEM and its mission. AAEM is there's several organizations to be involved with in emergency medicine. AAEM is a spectacular one. So for those that are new to the community, the American Academy of Emergency Medicine, otherwise known as AAEM, it's referred to as the conscience of emergency medicine. So it was established in 1993. It's a democratic organization dedicated to the principle that every patient deserves access to quality care and is led by a board certified emergency physician. We advocate for fair and equitable practice environments and fight to protect the integrity of the physician-patient relationship against the harmful influences of corporate medicine. AEM RSA is the trainee-focused section of the Academy. It's serving as the advocacy association specifically for emergency medicine residents and students, and the mission is built on three pillars: advocate, educate, elevate. So we're going to go ahead and get started. I have just a second. We have one of our panelists that is logging in just now. All right. So we have two panelists. I'm super excited for both of them. They're both alumni from my medical school, St. James School of Medicine. We have one of our residents joined in with us for our first part of the session right now, Dr. Essence Mehta, and we have Dr. Allison Spice that will join us as well soon. I'm going to go ahead and give a little bit of a rundown as to what's going to go on throughout the day and just some logistical things. So right now it's 9:10 Eastern Standard Time and 8:10 Central Standard Time. So about 8:15 CT, 9:15 EST, we're going to go ahead and start with the resident portion of this panel. This first session is going to run about an hour and a half. It will include the two resident physicians I just mentioned. They have a really great take. They both have a very interesting background, and they have a really interesting and unique perspective as to achieving residency for IMGs in emergency medicine. Then we have a little bit of a break. Then we have our second resident panel session with Dr. Matthew Carvey and Dr. Arya Zafirnia Hawkins. That will happen at 9:45 CT, 10:45 EST, also run for about an hour and a half or so. And then we'll have a little break, and then we'll have our final session with assistant program directors and program directors. And that will be, and there will be open chances for open Q&A throughout. And that will run from 11:30 CT or 12:30 EST, and that will be until about 1 CT or 2 EST. Whenever anyone has questions, if you guys want to ask your questions to the panelists, I would recommend using the Q&A button. I think that's just a lot easier for panelists to see instead of having to go through the chat. If you have any concerns logistically, if you're not able to hear me or anything is going on with the seminar, please use the chat button. And there's also an option where you can directly talk to me, the host. So you can click host panelists. And that would just be a lot easier to handle logistical sides and separate the questions that are meant for the panelists. All right, Dr. Essence Mehta is with us right now, and Dr. Allison Spison is joining in just a minute. We're going to go ahead and get started. I'm going to go ahead and introduce Dr. Essence Mehta. Dr. Essence Mehta is a PGY2 with St. Joseph Hospital in Long Island, New York. Dr. Mehta completed her medical degree at St. James School of Medicine in St. Vincent and the Grenadines. Dr. Mehta holds a master's degree in public administration from California Baptist University and a Bachelor of Science in Psychobiology from the University of California, Davis. Prior to medical school, Dr. Mehta worked for Adult Protective Services as a social worker. Dr. Mehta chose emergency medicine due to her desire to help patients when they are their most vulnerable. Dr. Mehta enjoys the variety of patient acuity and the fast-paced environment of the emergency department. In her free time, Dr. Mehta enjoys spending time with family, traveling, playing chess, and watching her favorite sport, basketball. And very soon we'll have Dr. Allison Spice joining us as well. I'm going to introduce Dr. Allison Spice, and then she'll go ahead and join the panel. Dr. Allison Spice is a current emergency medicine intern at the Kaiser Permanente Northern California program and a graduate of St. James School of Medicine. As a non-US international medical graduate, she has firsthand experience with the uncertainty, setbacks, and challenges faced by IMGs pursuing residency training in the United States. After initially going unmatched in 2025 and receiving the discouraging notification that so many fear, Allison chose resilience over defeat. Through perseverance, adaptability, and unwavering determination, she ultimately achieved her goal of securing an emergency medicine residency position. Her journey stands as a testament to the power of persistence and belief in oneself, and she is deeply committed to inspiring and mentoring others to continue striving toward their dreams in medicine, no matter the obstacles. Super excited to have both of you. Dr. Mehta, I can see you joined us right now.
Hey,
Would
good
you like to?
morning.
Good morning. Super. Thank you so much for taking the time to join us. We're really excited to have you. I knew when I knew about your background, I knew I would have loved for you to join us today. I think a lot of people are going to benefit from your perspective today. Just really quickly, just a quick introduction, or just going off the introduction. You mentioned your favorite sport was basketball, and you also enjoy playing chess. So, were you highly in there in high school? Were you like super involved in sports and getting straight A's at the same time? That's the kind of picture I'm getting.
Straight A's? No, not so much. I did decent, but I didn't get straight A's. But I played sports in high school. Yeah, so basketball is my favorite, but I do love all sports. And chess is actually something that I'm recently getting into. Yeah.
Oh, very cool. Okay, cool. All right, we'll go ahead and get started and just ask you some of these questions to start the symposium, if that's all right. Let's start with the very most basic question. I think a lot of us want to know what was the biggest surprise for you when you transitioned from medical school to intern year?
For my program, I can speak for it, but from day one, we were basically just thrown in there to becoming the doctor. So immediately we were sent to see patients, put in orders, make dispositions for the patients. So all of that kind of changed, like from being a med student, watching, giving your input here and there, to day one, you're in charge of this patient. What are we going to do for the patient? What do you think is wrong with the patient? How can you help the patient? So that was the probably the biggest surprise, is that there really was no like easing. Obviously, you had attendings there who will give you advice and back you up, but right away, you're in charge of the patient and you got to make important decisions.
Absolutely. And what out of all those things, what do you think you felt not necessarily unprepared for, but out of those things, what did you feel least prepared for from medical school? What was the biggest shock for you?
So I did my rotations in Chicago, and there I was able to see a lot of different things in the emergency department when I did my rotations, but there's still certain presentations that you'll see and you're a new resident and you don't know what to do. Just having to like deal with patients where you don't know what's wrong with them and you don't know what to do. So that's probably like one of the biggest things that I had to transition from as a med student.
You did your emergency medicine rotation in Chicago then too, I'm assuming?
Yes, I did.
Do you feel it was helpful to do your EM rotation in a busy city? You're practicing in New York, which I'm assuming is going to be very busy as well. Because I
Mhm.
know there's a lot of students that are joining us that are still deciding where they want to do their rotations, especially their elective rotations. Do you feel it was
Mhm.
really helpful to be in a busy city like Chicago?
I think it was helpful because even though like I didn't rotate at a level one trauma center, I rotated at a level two, I still saw like a lot of trauma. I saw a lot of really sick patients. So I do think it was useful. I know Allison went to med school down in Texas, which I think is more kind of community where she was at. So she'll be able to give that side of it. But I do think that it was really helpful being in a big city. You just see a greater variety of patients.
Yeah. All right. So I know a lot of people are really nervous about just the busyness of residency, especially coming from med school when we're already so busy studying and going to rotations. But apparently, every step is just that much more intense. What do you think? What do you think were the habits that helped you survive, say, the first 3 months of your intern year?
Again, for my program specifically, you start your first month, which is July. You start that month in the emergency department. And so the schedule is not, the hours are long. You work 12-hour shifts, but the schedule was not that bad for us our first month. We actually got like 4th of July off, and then we had different type of orientation days. So it wasn't too bad that first month. But I feel as a or those first 3 months were not too bad. As a second year, I feel like for my program, this is the most intense year where your schedule is pretty busy. I actually worked Monday through Friday, and thankfully I had Saturday off, and then I work again tomorrow. So I just luckily got this day off to be able to participate. So it is very busy on this rotation I'm on, which is PICU or pediatric ICU. Like I said, it's really every day, just one day of the week off. So 12-hour shifts. So it is busy.
It's the full 80-hour work week, right?
Yeah, so I work six, so it's 72 hours. So I work Monday through Friday, 12-hour shifts. So that's 60 hours. And then I'm off today. And tomorrow I have another 12-hour shift. So 72 hours this week.
Oh my gosh. Okay. Got you.
Yep.
I think a lot of attendees here, and I've seen this in some of the questions that were asked, they want to know essentially, number one, a lot of people want to know how they can best position themselves to get into an emergency medicine residency. But I think a lot also want to learn from people's experiences, especially residents' experiences. So I do want to ask you a question about both your early residency as well as late med school. Do you see a mistake that medical students, especially in the third and fourth years, are making over, and do you see a mistake that that interns are making over and over? And is there any way to avoid some of these common mistakes?
The best way to position yourself for emergency medicine is there's really not an amount of studying you could do between the end of fourth year and the beginning of intern year to prepare you to turn that light switch off and now be the doctor. You just have to jump into the role. You have to own the role. You have to realize you are the doctor now and just do your best. You are going to have a support system, your seniors, you'll have, like I said, other attendings there to help you, your program director, leadership. So although it is like an automatic like light switch where you change from just being an observer to the person in charge of saving a life, you just own the role. As far as like applying and being the best applicant, I know it may sound just basic, but the best thing to do to prepare yourself and make yourself the best applicant is to do well on step two. I feel like that relieves a lot of stress. If you get a good score, you open a lot of options for yourself, and the application season can be less stressful because you'll get a lot of interviews.
There's a lot of students that are joining in. I believe Dr. Allison Spice just joined us. Is that correct, Dr. Spice?
Yes, I'm here. Can you hear me clearly?
Perfect. Yes. Just to piggyback off your question, Dr. Mehta, really quickly. A lot of students have been asking about step two scores, especially those that are joining us that are non-US IMGs. They wanted to know what are the scores that make them competitive. There's a lot of numbers that are being thrown out there. In your perspective, what would you say would make a US IMG competitive and a non-US IMG competitive for step two?
So I'll let Allison speak to the non-US IMG, but I would say for a US IMG, at bare minimum, if you could get at least a 230, that will position you. I hear Allison's in the hospital. If you can get at least a 230, that will put you in a decent position to get some good interviews. It's becoming more and more competitive every year. I know there was one year where there was a lot of leftover spots. That times are changing. Emergency medicine is very competitive, but obviously there's ways to get into residency without the amazing score. Like perseverance will get you through too, but just for peace of mind and make it a little bit easier, I would say at least a 230.
I agree with
Doctor,
that.
Dr. Spice, I had introduced you to our group just a little bit earlier. Thank you so much for joining us. I don't think everyone knows Dr. Spice is actually joining us from California, super busy schedule. We're so grateful to have you here. So just to piggy off that question as well, actually, for the non-US IMGs that are joining us, what would you say, Dr. Spice, is a good range to aim for a step two score?
I definitely say the higher the better. I definitely say that don't get discouraged if your score is not what you want it to be. True disclosure, I scored 217. I still ended up gaining a residency. Is it the most preferable or desirable situation? No. That's why I say if you have the time, don't pressure yourself about these pressuring to do your step two, pressuring to get it done, pressuring it to because you want to start your electives or take time. Do whatever is right with for you. Do where you feel that you're going to confidently score between the 230s and 240s, because then a lot more doors will potentially open up for you. And then just make sure that your application is still all rounded with not just scores, like you're also involved with emergency medicine, et cetera. That being said, my biggest take back, if I had to do it all over again with my score of 217, is that I would probably have taken the time off. Who cares if I had a gap in my schooling? I would have taken more time, prepared properly instead of feeling rushed and get it done.
Now, you bring up a really interesting point. I'd love to know both your takes on this. Is there's a lot of concern about taking a gap. Now, I've heard that IMGs, for people that are IMGs, the gap year is not as much of a concern as many think that it is. A lot of programs are understanding of why that might be. In your experiences, do you guys, whether it's colleagues or your own experiences, do you guys think that the gap year is as a big of a deal as everyone makes it? We'll go ahead and start with you, Dr. Spice.
Sure. I think it depends on how you approach it. So, do you have a good reason as to why you're doing it or why you're not doing it, as far as with that? So, then if you have an explanation for it, you have to have an explanation for it and why you're doing it. And if you don't have an explanation of why you're doing it or a good reason for it, then that can be held back. But as long as you're able to show in regards to that, you're good. So I still attest to, and I still say that 100%, if you can explain why you're off and you have a good reason why you're off, do it. Take the time.
Dr. Mira, what's your take on that?
Yeah, I agree. So I personally didn't have any gaps. I finished in 4 years, but I know several of my co-residents and other residents that I've met that did take time off, whether it be to study for step one, step two, their family issues, whatever. I've seen them match. So I don't think it's that big of a deal if you have some gaps. Like if you took whatever 3 months off to study for step two to make sure you get a solid score, I think that may be worth it. I think that it'll be held against you as much if as you got a lower score.
Okay. By the way, Dr. Spice is going to join back in. She just had a little technical issue. Okay. What, Dr. Mehta, if you don't mind me asking, I know I'm beating the horn with this, but I've gotten a lot of questions about students that don't want to make certain mistakes, but at the same time, they don't want to put their energy into the wrong things. A lot of third-year students who are entering clinical rotations and fourth-year students who are currently on elective rotations, they reached out to me and they wanted to know they want to know your opinion on this. What are some things that medical students, especially in the application season, are spending a lot of time and energy on, which is not as important as they think it is, and what are some things that they're not spending enough time and energy on, especially in those third and fourth years, that is a lot more important than they might have thought it was.
So I'll start with the more important things, I would say. The most important things would be to study and do well in each rotation. Your grades don't really matter, but that studying you do during third year only prepares you for step two. So the more time you spend studying, working hard in that, you'll be prepared and ready to take step two by the beginning of your fourth year. So I would say when you're done with rotations, just spend the time studying. It's going to be a rough year, third year, but do well, do as best you can in every rotation. That way, when it's time to study for the comp exam or whatever your school may require for you to take step two, you're not stuck spending a lot of time. And again, if you do need to take the time, that's more important than just getting it done and having a lower score. So I would just say focus on studying, doing well on your rotation so that you're prepared for step two. Some things that I think are not as important are just like being obviously EM and RSA, those are amazing groups to be a part of, but just being a part of any old thing. Like if you're not in a leadership role, like if you're not the president, vice president, or on a board, it's just hanging out with these type of groups is not going to serve you as well as studying hard and doing well on step exams. If you can get leadership positions or if you're spending time going to conferences where you're actually going to present and actually go there and make real connections that'll help you match, I think that's worth the while. But if you're just a member and not really a leader, I don't know how much that actually helps you when you're applying.
Understood. You hit on something pretty interesting about third year. So just as a side note, I kept hearing in second year about how third year is amazing. I don't know why people think third year is so fun. It was very intense. I found it very intense. I don't know why a lot of people were mentioning it as like oh, once you're done step one, like it's all uphill from there. I found it very intense, and I feel like it is an important year, especially with doing your rotations and studying after worrying about step two. But I'm glad you hit the head on that because even on Reddit, I see that all the time. Just like, oh, third year, it was my favorite year. That's interesting.
Yeah, you're out of the classroom, right? So I get people think it's being in clinic or being in the hospital is it's more interesting than being at a desk and studying embryology, I guess. But yeah, third year, it's intense. But if you prepare, like I say, try your best on especially all your core, your IM, your family, your peds, all of those rotations. Do your best you can, and that way, when it's time for step two, you're gonna have smooth sailing with passing any exam your school may require so you can get right to step two.
Cool. I have a question from the audience. Someone would like to know how problematic is it for the match after a failed step one? Do you have any thoughts on that?
So I do know people that have matched with failing and their IMGs as well. So the thing is, when I say work hard on step, and that's only to make the process smoother. I'm not telling anyone that it's impossible if you have a fail or if you failed classes because or you go unmatched. I know people that have failed step one, failed step two, and they matched. They had a tough time. They had to go through soap and it was difficult, but they made it. The thing is about not giving up. And I know even Allison, her not matching, she still pushed through and ended up at an amazing program. Anyone who's from like the western part of the US knows that Kaiser Permanente is one of the best hospitals you can work for. So there are success stories. But if you haven't failed, obviously do your best to not allow that to happen. But if you do end up failing one of the exams, it's not the end of the road. I know multiple people that have failed different step exams and matched. Ultimately, make your life easier, do well the first time, try to pass. But if you don't, obviously don't give up if this is what you want to do.
Understood. Thank you. We have another question as well. I think this might be a little bit more suited for Allison. It's a non-US IMG question. We'll wait for her to log back in. We'll answer that. Anyone else has questions, please go ahead and just use the Q&A box. We'll ask that. But going back to a few other questions that some people wanted to know, we hear a lot about networking. Now, it means something different to everyone. How important for yourself, but also maybe some colleagues, whatever it may have been, how important was networking in terms of positioning yourself for residency?
I think networking is very important. So if you can, on your rotations, especially when you're on emergency medicine electives, getting in good with the leadership there. If the program director likes you, or if it's a rotation that doesn't have a residency, just whoever the leadership there is in the emergency department, getting to know them because it's a small community. So if you're rotating in like Chicago or in Texas, I can tell you all the emergency doctors there in that area, they know each other. So if you're getting good with one, have one put your name out there, you'll be able to at least get an interview. And even at my point as a second year, if you reach out to me and you apply to my program, I could probably help you get an interview. Connections are really good. Work hard, don't put all your eggs in the connection basket. But the more people you know, the more people that you make a good impression on, the better you'll fare in the end.
Understood. There was a question someone's asking about achieving SLOEs. We know how important SLOEs are. One of the issues a lot of IMGs are having is their medical school does not participate in the VSLO. In those situations, I'm not sure if yours were done through VSLO or if that was required at that time, but as of right now, for those programs that do require VSLO, the hospitals that do require VSLO, what is your advice for still being able to achieve a sub-I at that location that you want to do residency?
Thankfully, if you're a St. James student, we don't use, at least when I was there, we didn't use VSLO, but we did have partnerships with several hospitals that had residency programs. So you could get an eSLO to use during your residency application. So if your school doesn't have any connections, you can reach out. Hopefully, maybe there's some alumni that may have rotated in different places and find out what they did. But I think typically all programs, even if maybe someone never rotated at this certain hospital, you can do your own legwork. Reach out to the hospital or to the program. Tell them what school you're from, what do they require to have a student rotate, and then go back to your school, provide that information, and hopefully they're willing to help. Because I know this didn't have anything to do with emergency medicine, but I was at the end of my rotations and I wanted to do an elective close to home. So I reached out to my school and I told them about the doctor who was willing to precept me. I gave them all the information. They filled out the paperwork. And then I was able to do that elective close to home. I think the same could be true with some of these programs that are able to give you an e-slow even if your school is not connected with them. Hopefully, you got to start early. Do this because sometimes it takes a few months to get approved and make sure the preceptors get paid and all that, whatever logistics. But I do think it's possible to do some of the legwork and get into these programs to rotate there.
Understood. We have a few more questions coming in. An attendee's asking, what advice do you have for future interns regarding creating an effective study schedule among a busy resident schedule to make sure you are passing your EM exams?
In my program, it's implemented into our work as well. So we'll have weekly readings that are assigned, weekly assigned readings and assigned questions. And then every Wednesday when we have didactics, we'll have quizzes and lectures. So there is a lot of studying that's already implemented into your schedule as a resident. You have to do the required readings, you have to do the required questions. I think most residency programs set it up like that. So in addition to work, you're going to have study time already in your schedule. But I said, especially when you're on emergency medicine blocks, you'll have days off. So you rejuvenate for half that day and the other half of the day try to get as much studying as you can. I feel like the only really, at least for my program, the most important exam is the in training exam, and that's in February. So a lot of other specialties have their in-training exam in the beginning. They may start residency in July and they have an in-training exam in September. So that's really close. Thankfully for emergency medicine across the nation, everyone takes the in-training exam in February. So you have 8 months or so to study for that exam and do your best. And then when you're on off-service rotations too, a lot of times those schedules are a little bit better. So you'll have more time to study. For us, intern year, you do an anesthesia ultrasound elective not elective, rotation. On that rotation, you don't work weekends. And most of the time you're done by 5. So there are blocks where you're going to have a lot of free time to study. You just have to kind of talk to your seniors and they'll tell you, oh, this is an easier rotation, the schedule's lighter. Make sure you use this block to study hard or whatever for the in training exam.
Understood. I got quite a few more questions here. I'm not sure if you may be able to answer this one, but uh, let's see. Does it matter if your EM rotation grade and evaluation is not on your MSPE as long as you still have a SLOE from them?
So let me see. I'm trying to remember because I did 3 emergency electives, and I know one of them may not have been on my MSPE. So the short answer is the SLOE is more important. So if you have the grade pending or whatever, because you had to take it right before applications are due, I think that's okay as long as you have a SLOE in, because they use the SLOE to decide who's going to get interviews. So as long as that's in, I think you're okay. And the grades, hopefully they'll be ready by the time the programs make their rank list. So yeah, yeah, having the SLOE is more important. So I think that this person is asking, maybe they got their SLOE completed at the 3rd week or whatever of the rotation, and they're able to submit that on time, and then the grades are posted later. I think that's what they're asking. So yeah, I think the SLOE is it's important. Yeah.
Okay, understood. To piggyback off that, I actually have a question about just the MSPE in general. Is that if we have slows, is the MSPE as that important anymore in terms of noteworthy characteristics or just how you did in your rotations, or do slow just take priority over that? Because I haven't really heard for emergency medicine too much about if the MSPE is still as relevant.
Yeah, and this is all my hunch and just asking questions. Third years are allowed to be more part of the interview process, but for incoming residents. But I definitely think that the SLOE is more important. That would be my
Yeah,
hunch. The SLOE is more important.
understood. I think Dr. Spice just joined back in. Dr. Spice, are you able to hear us?
Yeah, for sure. Sorry about that, guys. I just had to go see a patient.
No, no worries at all. We have a question that might be pretty much geared towards you. Someone's asking, how do we secure electives or sub-Is as a non-US IMG? Most of the hospitals don't accept international students for emergency medicine.
Yeah, for sure. So don't get caught up on the actual places that will say on their website that they do not do international students. So if there's a place that you really want to go to, I highly recommend that you reach out to them, reach out to the program director as well as the actual coordinator, because sometimes it may not be an actual elective, like a sub-I that you can do, but sometimes you might be able to do observership. So then you might get your way in to see the program at least and put your face out there. Other things that I used for securing my away rotations is I put it in the chat here. It's called Clinician Nexus. It's free for students to find or to put an application, sign up for it. And it gives you an idea of anything across the US that's available and open for emergency medicine, and also for all other rotations as well. I used that and I was able to secure 2 rotations with that. Hennepin was Minnesota for an ultrasound rotation, and then also South California in Riverside was an emergency medicine sub-I.
Nice. Okay. Did not even know about that. Clinician Nexus. So
Hmm.
it's in the chat in case anyone's looking for it. There's an there's actually a question in the chat that may be related to what we just answered. Someone's asking, can an observership get you a slow, or does it have to be hands-on?
It's usually sub-I. So sub-Is usually get you a slow, but a observership could potentially get you a letter of recommendation. So a lot of times to apply for emergency medicine, you need to have at least 1 slow. Some programs want you to have at least 2. But definitely besides that, it's always good to have from a good academic program potentially to have an LOR, letter of recommendation, besides the SLOE, right? Or you can have those conversations with those programs saying, I know I did an observership. Is there any opportunity that I can come show you what I'm worth? And would you potentially allow me to do a sub-I? Because you never know, rules can be bent, things can happen, maybe they really liked you, you impressed them, etc. So it might be something to think about. Or they might even be able to put you in contact somebody else within their network, and it could even be at a different hospital, a different state, saying, oh, I know this place that can take you, and why don't you go here, here's the contact information. So you never know. So unless you ask, what's the worst case scenario? They're going to say no.
Yeah, very true. We have a question for you guys about a lot of questions about slows. Someone wants to know how many slows can or should we submit? And if we can get three e-slows, is it helpful at all to get them from other specialties like IM or surgery, or should we just stick to EM? Dr. Mesa, do you want to answer that?
Sure. And Allison hopefully can correct me if I'm wrong. I don't know that you can get an e-slow from a different specialty. You can get a slow filled out, but it's not the e-slow, which is the most important. An e-slow is from an emergency medicine rotation that has a residency program. Like for me, I only rotated at one program that had an emergency medicine residency. So that was my one E-slow, but I was able to get slows from my other emergency medicine electives, even though they didn't have a residency program. So I would say if you can try at least get one e-slow, but you can have slows filled out by other emergency doctors in hospitals that don't have residency programs. You can have a slow completed by another specialty, but I don't know how useful that will be. I would say gear your slows to all emergency medicine rotations and at least try to get one at a rotation that has a residency program. That's the E-slow.
No, it's e-slow. Okay. Now, this is a question a lot of people wanted to know actually, and someone asked it in the chat as well. Are there any electives? So I'm going to ask two questions to both you guys. I'd love both your input on this. Are there any electives you strongly recommend to better prepare for residency, or would you recommend mostly EM rotations? And I'm going to follow up with that question, something that was asked a lot. Does it matter if you do rotations and specialties other than EM in your fourth year, especially when it comes time to apply or get interviews, or should you mainly focus on doing EM rotations?
So I think my school, I think the max you could do is three. So you can't like spend your whole fourth year doing EM rotations. Emergency medicine, we cover all the specialties. So any elective will be useful just for your knowledge and to prepare you for intern year. Because like I said, in my intern year, we have an OB-GYN rotation. So that's one of our core rotations. Like we have to deliver a certain amount of babies in order to graduate residency. Other off-service rotations will be useful for you. Let's see what else. If you could do like anesthesia, like that, ultrasound, all of because from day one at my hospital, if you're ready and you feel like you'll intubate a patient. So if you took an anesthesia rotation where they allowed you as a med student to intubate, you'll be super prepared. There's so many, like I said, emergency coverage. So even if you did an cardiology elective or a GI elective, all of those electives matter because you're going to see all those things coming into the emergency department, and then you'll know how to better manage those patients. And when you're talking to consults, since you did a GI elective, you'll know what they're looking for when someone consults them from the emergency department. So yeah, any specialty is great to do an elective. But like I said, for application's sake, I would say the slow should come from an EM rotation. But yeah, pick whatever you're interested in. It's more than likely going to touch an area of emergency medicine. So yeah, rotate in whatever you're interested in.
Dr. Spice, is there anything you wanted to add to that? No, I think, oh, sorry. She'll be back in just a minute.
Yeah, she
Someone, sorry.
I was just gonna say she's so awesome for logging in while she's in the
I
hospital.
we're honest, we're all honestly so grateful to both of you. Thank you guys for taking
Well,
the time.
it's one of those things that I was supposed to be like sick call, and so then that's why I ended up being here. And then I was
She
hoping
got
not, but of course
unmuted.
it always happens, right?
Everyone's getting to see firsthand what life in as a EM resident is, so I think this is actually perfect.
Yeah, yep.
Dr. Spice, someone was just asking about rotations and if you have any particular recommendations for which specialties or areas of rotations they should be doing in their fourth year.
I actually think she was just like accidentally unmuted and she was.
Oh,
No,
okay.
I'm here.
Oh,
I'm here.
oh,
Yeah,
okay.
I was just trying. I saw somebody in the link. They wanted the clinician nexus link, so I was like working on that. So then, of course, I have to toggle on my phone here, trying to figure it out. But
Oh,
100% is if I had to do it over again, I would say go where you want to start early to try to find your rotations, and two, go where you really want to go.
Hmm.
Don't like, unfortunately, with me, I felt like I was just trying to find anything and anything because I
Yeah.
just wanted to do it. But with all that being said and done, Minnesota, they don't really take any IMGs,
Yeah.
or at least non-US IMGs. They'll take a US IMG, but not a non-US IMG. And same with Riverside in California. So right there, I had two interviews on the spot pretty much for a whole month, but they weren't going to take me.
Hmm.
You know what I mean? So
Yeah.
those are things that you want to take a look at too, because you invested that money and you went there and everything. So really look at potentially one, will they take you? Two, is it a place that you really want to be? And then put it that way, make those connections that way.
Now, I know there's probably going to be quite a few people that are non-US IMGs attending this. I'm sure they want to know about the visa situation right now, given everything that's happening. Could you briefly touch on that, just about your experience with the visa hurdle, starting your residency?
Yeah, so full disclosure to everybody as well is that I did not originally match, and I was devastated just like everybody would be. And so I sent an email to all the programs that I interviewed with saying, unfortunately, I didn't match. Congratulations on filling all your spots in your for your program, and anything that you saw on my application that I can improve, or what would you recommend, like my next steps going forward type idea. And a whelming, like I had 8 interviews and 5 places did get back to me. 2 places I actually had personal one-on-one interview follow-up calls with them. And they decided that no. One place said that no, your application's great, nothing really stood out, red flag, it just really had highly competitive year.
Hmm.
One did, though, said that one of my potential e-slows that I had was not particularly in line with showing my dedication to emergency medicine. What that
Hmm.
means, don't know. Take it as you will, but obviously it's not good. It just showed something potentially was impacting me. So maybe I was lower on the list of ranking with the program compared to where I probably would have been higher if I didn't have that letter, opposed to having it type idea. That being said, is that as a like a non-US IMG, is that you really need to one, make sure that you have everything in place and that you understand what you need to do for your visa as well. Like I had one program ask me like, "Oh, are you aware that it's hard for non-US IMGs to get their visa and to practice afterwards in Texas?" So you may
Hmm.
go to one of these states that necessarily may be more difficult after you've done residency. Are you going to be able to be actually trained or stay in that state? So they'll ask
Interesting.
you those questions. So make sure you're prepared for those questions and be like, absolutely not. I know previous people that have been there, but not just that hearsay that you physically have contacted or looked at the licensing board requirements. So fast forward, I was offered the position where I am right now in June. And so then I had to do the visa, all the visa requirements. And the visa requirements are pretty easy. It's just a lot of paperwork and following up on emails and with ECFMG, etc. That it's the biggest hurdle is that when you start your program date, if it's early enough for ECFMG. So, for example, they had down that I was going to start September 1st, even though I started the process in June. If that gets sent to ECFMG, ECFMG is not going to process my application right away. So, oh, we got 3 months. And
Yeah.
but the reality is that, yeah, I'm starting in September, but I still have to do all the onboarding, all the other information. That's like just the first step. Because
Right.
after you do ECFMG, you have to do your, so if ECFMG helps you get what is called your DS 2019. And then when
Mhm.
you're 2019, you get that, you need to get your statement of need, and you need to get as far as your passport authenticated, etc. So there's like steps that you need to take. So what ended up happening, and then this is like sometimes the program knows or doesn't know, is that they just changed my potential start date to July. And within 10 days, my visa was issued, my DS 2019, which is
Mhm.
then once you get your DS 2019 form, then you get the statement of need from the government of Canada. It's just an email that you send them. And
Mhm.
then you take your offer letter from the program, all that information, and then you go to a port of entry to the United States. So if you're flying or if you're driving, right, to the border, and you
And
get
this is different
issued
for
your visa right
Canadians.
there. Yeah.
This is different for Canadians versus other IMGs, if I understand
That's
correctly,
right.
right? Okay.
That's right. So this is more for Canadians. For a non-Canadian, non-US IMG, a lot of times what they have to do is once they get the DS 2019, they need to schedule a visa appointment at their
Okay.
embassy or at the US embassy in their country where they are. And sometimes that could be the delay. And that's where Trump comes in, where he's had different regulations and such, as far as like at one point last year, or the interviews were canceled or stopped for a time period. And it affected quite a few of people trying to come in for
Mhm.
intern year. Right. But Canadians, we don't have to make that appointment. We just strictly go right to the port of entry to the border.
Understood. Perfect. I'm sure that was very helpful for a lot of people attending. Okay, so if you guys had to go back and change one thing about both third year and fourth year, is there anything that you guys would do differently? We can start with you, Dr. Mehta.
Let me think. I don't know, not necessarily. I feel like I said, thankfully for me, my process was pretty smooth sailing. I was able to get my step 2 done like right at the last minute to where it was on time for applications. My slow, I don't know, everything worked out for me. I thank God it wasn't just me, but everything pretty much aligned to where, like I said, I could finish in 4 years and match that year. It worked out well. There's always more studying to do. I wish I could have gotten a little bit higher on step 2. I don't know. I feel like everything worked out the way it was supposed to. But yeah, not too much. I love that I went to Chicago. I had a great experience there. Yeah, so it just worked out. I wouldn't really change anything about my process.
Understood. Dr. Spice.
You got it. If I had to change things going back in third and fourth year, I think I would have paid attention more. And I don't think I really did a good job of this during medical school, is that when I was seeing patients, of really thinking about what the differential diagnosis was. Like, I don't feel like my school was really well for that. A couple of rotations I did, but you weren't thinking outside of the box. You're just thinking what the diagnosis is, not like what is it, why is it not something, and why is it something else instead of other things. So, like, for example, if you're easy to say, emergency department, right? So, somebody coming in with shortness of breath, okay, is it an MI? Is it a pneumothorax? Is it pneumonia? Is it COPD exacerbation? Asthma? Is it a PE? And I don't think I did that enough during med school to really think of that. So then now when you come to the resident life is, oh, you feel lost in the first couple of months, and everybody does, right? But then you start to think of, oh yeah, I remember, yeah, this is what we learned in the textbooks, but you weren't really putting it into practice because you're just thinking about it when you're doing your questions, but now you're really seeing the patients. So that would be the thing. The other thing for me, just because being a non-US IMG, is that, you know what, it's just, you got it. Don't worry about what everybody else is saying. And the only person that's going to take care of you is you. And the only person that has to deal with a high score, low score, or whatever commitments, resilience, whatever, is you. So definitely lean on your friends, your colleagues, etc., especially if you need that motivation to keep going or when you lack it. But at the end of the day, it's only going to be you that you can blame for succeeding or not. and it's only you of how much you're going to put in, and just not give up, just keep going, because it will happen. And just like Essence says, like, it happens for a reason. Look, I'm at my number one spot. It just happened the
Yeah.
way it happens.
Yeah. That's a really good take. I appreciate both of that. Now, this is a question I think both of you are perfect for, and I think it's a question a lot of people have. So I'll actually bring this question up also in the PD section, but considering both of your backgrounds, someone's asking, what value would having a non-traditional background, professional, such as professional degrees, research experience in different fields such as philosophy, sociology, psychology, in the EM application be for the EM application? So in general, what a non-traditional background, how have your guys' experiences been?
I guess I'll start. Definitely a non-traditional background of one shows that you are adaptable. Two is that you can persevere. And three, it's going to show that one, you have experience in something else, so you have life lessons. So that's one thing that you have to take. So it could be taken negative and positive with anything. I even had one program when I reached out to them, they were honest with me and they said that some programs will love that you were a nurse before, Allison, but some programs will hate it. You know what I
Really?
mean? And it just goes on what their stereotypes and what their perspectives are. So some people might love that you were a scribe or tech before, and some may not. They might like to have people that don't have any experience at all. And so being able, a lot of times your non-traditional pathway is teaching you potentially how to talk to patients, how to be at kind of their level, and how to interact with different personalities, because your residents are not going to be the exact same as you, and everybody has
Mm.
a different opinions and perspectives, and being able, your background is going to help you to deal with those different challenges.
Dr. Mesa, would you like to add to that?
Yeah, I can say similar things. Like I worked as a social worker. I think it was received well. Most people were interested about it and they asked me about it during the application cycle. Oh, how did that help you? What made you want to stop that and start EM? So I think it was an interesting talking point. But like Allison said, everybody's different. There are some people that, are going to see that as, oh, she didn't go directly from undergrad to med school. They may not like that for some strange reason. Everyone is different, but I do think the programs that appreciate it, that's where your match, and that's where you'll be better suited anyway. You want to go to a program that is excited about your background, can see the value in your life experience and all the things that you may have achieved before ultimately going to med school. I think you will match where you're meant to be, and there's someone that's going to be interested in your background, whether it be, oh, I was a musician for this many years, and then you'll come across a PD who loves music and loves musicians, so you'll just end up matching there. There's always naysayers and people who don't like certain aspects of whatever, but there's people out there who do. There's people out there who do, and that's where you'll go, and that's where you'll best succeed anyway. So I think that the life experience is great and it provides a level of maturity and experience that some other applicants just don't have. So I think explain it well in your application and the right program director will see the benefit in that. And yeah, it'll be good.
Very positive response from both of you guys. Appreciate that. Now, just to piggyback off that, the little funny story I heard, important thing is to never pretend about certain backgrounds. I think I heard a story about someone who said that they really love playing guitar or are very good at playing guitar. And then in their interview, there happened to be a guitar there. And I think one of the interviewers was just like, "Oh, I love playing guitar." And then he brought the guitar and he wasn't able to play it. And so that was not a good look on their part. But I just thought it was a funny story just about talking about backgrounds. So we have a question about how heavily do programs weigh SLOEs from community versus purely academic sites for IMG applicants? Go ahead, Dr. Mason.
Yeah, I don't think there's any different as long as the community hospital has a residency program, and if the academic, it's weighed the same. As long as the only thing that is weighed differently is whether your rotation had a residency program or not. So the ones that have a residency program have the heaviest weight. Community hospital, rural hospital, academic, none of that matters as long as they have a residency program.
Understood. Dr. Spice, anything to add to that?
Yeah, I think they're weighted the same. I think just be prepared that if you have slows from different, like just community or just academic or a mix, is that you might have a question during your interview of what do you prefer? What do you see you getting all of your education and training from a community versus academic center? So just be prepared to answer those potential types of questions that you may have and understanding potentially where you would like to learn. Do you like an academic center versus a county versus a community type of academic, and just be honest with what you feel you probably will thrive in for a residency.
Perfect, understood. A lot of students want to know, this was actually asked outside of the session, and I just remembered it right now. That was an interesting question. A lot of students want to know some of the things that are a little bit more difficult to ask, just in terms of being professional, staying professional. When the time comes for applications, let's say you don't hear back from any of the programs you apply to. Let's say you haven't gotten interviews of the programs you wanted to, or anything of that sort. When is it appropriate to start reaching out to program directors? And what's the most effective way to get their attention? Because we know they're going to be very busy at that time. Do you guys have any experience with that, or any of your colleagues have any experience with that that you can share? We'll start with you, Dr. Space.
Yeah, for sure. It was probably beginning of December and probably end of November, beginning of December. And everybody, we have this magic number as IMGs in our head that we need 20 interviews. You know what I mean?
Mhm.
So it's like I started reaching out. I emailed a bunch of programs that I was really interested. I want to say I probably sent out like 30 emails maybe. And I just said, hey, I don't know if you really realized about my application. And I just highlighted something about my application that
Mhm.
may not necessarily have been in my ERAS at that time. And then I always put my picture, my headshot. So then it puts a
Mhm.
face to a name. And it could have been like, oh, did you read my latest article in AAEM? Or it could be research or whatever, et cetera.
Right.
And then from that, I actually did get, I can't remember if it was one or two, but it definitely, I did get one. I felt like I got one interview from that. And
Mhm.
so that was definitely interesting of that, hey, if it works and if you put the work in, something's gonna come through it. And it's just all about making your network bigger, regardless if you go there and match there or not. So that's my take on it. I would say it's never too early, it's never too late. I feel like maybe I did it a little too late because a lot of programs now being in a program, a lot of times they're winding down December to mid January, just because they tend to do a lot of their interviews really heavy, is between October, November, and like the first week of December. And then it slows down quite a bit because of the holidays and everything too.
Dr. Mehta, do you have anything to add to that?
Not really. I honestly, I didn't reach out to any programs that I didn't interview with. I do think a slow may have came in after, and the programs that interviewed me, I sent them an email saying, I got another slow that came through. But I think it's up to, I don't think there's anything, definitely not. There's no harm at all in reaching out to programs. I just I personally didn't do it. But I don't think anyone sees it as a negative. And yeah,
No,
Allison
no.
said, I would say, yeah, December, if you're wanting to reach out, I would say that early December would, like she said, because now my program, I think they're done with interviews. Yeah, early December would be good to try to cast a net to get an additional interview. I wouldn't wait any longer than that.
Understood. Perfect. Thank you. Dr. Spice, would you like to tell us a little bit about how the SOAP process works, just in terms of how you successfully navigated it? Because I think that's also very rare.
I didn't successfully navigate it, but I understand what you're saying. So definitely going through the soap is so when I was actually in the Philippines on an island called Boracay, when Match came out, I was all dressed
Mhm.
up because I was thinking I was going to celebrate and be like super excited. And I remember getting the email and it didn't come right at 10 o'clock. It was like a couple minutes after. So I knew something was off. Like I minute 10 o'clock hit and I didn't get the email. Congratulations. It's so sorry you didn't match into any of the positions. And I was like devastated. So then, of course, time change is different. That's 10 o'clock at night in the Philippines. And so I literally had to stay up around the clock to tailor my application to SOAP. Reiterate, because you only have 40 choices that you can to programs you can apply to. So literally I applied to every open emergency medicine, especially if they're offering the visas
Hmm.
in some traditional kind of spots and family. And then every day you had to check your email to see if you were going to get any invites. I did not have any invites. I was on social media, on Reddit, all this stuff. And tons of people were saying the same thing for non-US IMGs. I feel that SOAP is a process for US IMGs and also for DOs. So those
Yeah.
ones who did not match and then they get into it. Okay. But once SOAP is done, and then Friday, if you get that email saying you did not match into any position again, and then the people that have already matched, they find out where they're going. I feel like that's not the end of the game. So there's different accesses on websites and information online where you can find out where the programs did not match as far as with that, and you just have to keep on plugging. There was a new program, I believe it's in Michigan, Illinois, or Michigan, I can't remember. And they were in the process of just getting certified. They really
Mm.
wanted an interview with me, but they understood their accreditation fell through. And
Mm.
so they just said that they'll keep us in mind and contact me type thing when it happens, if it happens, type idea. But then I landed this position here. So always keep open for any opportunity. And I was just trying to get into anywhere. Could be transitional, could be surgery for 1 year, it could be like family medicine, because I hear about people even switching specialties as well. So I was just doing that. And then I was like, okay, what am I going to do for the year off? So then I hunkered down. I was like, okay, I'll really do my step three then, you know what I mean? Type idea
Mm.
and get ready that way.
Understood. Super helpful. There's actually quite a few questions people are asking about research. So in general, I'd love to know you guys' opinion. Do you guys think research is very important to the EM application? And if so, do you have any recommendations for how people should participate in research? And go ahead, Dr. Spice.
I think with research is that you have to be passionate about it. If you're not really overly passionate about it, don't stress about it. I think there's other ways that you can attribute to the community instead of being research, because not only looking for research, they're also looking for leaders. So you
Mm.
can be involved in different committees within AAEM or SAEM or even EMRA or ASAP. And being
Yeah.
involved in those committees also shows you have leadership skills. So you don't necessarily, we all have research. I don't think you need to have a saturated application and have 30 research publications, etc. Yes, it's impressive, but at the same time, too, is what are you, a bedside person, or do you want to be doing tons of research? So just a matters of where your passion is and how you present yourself in the interviews as well.
Dr. Mehta, do you have any opinion on research?
Yeah, I agree. I feel like with emergency, so most of the residency programs are community based. If you look at the numbers, most are community based. Those types of hospitals, my hospital, the hospital that Allison is at, I believe they don't care as much about research in EM. If you go to a university hospital, an academic hospital, they may be more concerned about that. I think most medical schools require you do a research project or something. I think within emergency medicine in general, unless you're, like I said, trying to get into one of the bigger university programs, I don't know that they care as much about research. Do your due diligence. I would say at least have something research related. But yeah, 30 publications and even five publications, I don't know how much that will help you.
Gotcha. Yeah, that's a common theme I've been hearing. We have quite a few questions in the chat. Okay, so someone wants to know, we're trying to find the most relevant questions. Okay, here's one. What qualities do EM programs look for specifically in IMGs that separate strong applicants from the rest? Dr. Spice, do you have anything to mention about that?
I think it's they don't want to tell you what you have to do. And I
Mm.
think you should show that on your rotations. So like when if you're always sitting down, and you're not asking questions, and then you're just waiting the time go by, you're not interested. You know what I mean? That's definitely a red flag. I think what you should be doing is like eager and willing to learn and constantly looking up stuff and trying to figure out what you can do or what you can do next to better infiltrate that program, I guess you could say, and find out how the workings is
Hmm.
goes along. But definitely you need to, one, be attentive, two, ask questions, three, show the initiative. Saying, oh, I see a patient just got put in room 5. Can I go see them? Or do you
Hmm.
mind if I go see them? You know what I mean?
Being
Those
eager.
types of things. Yeah. But there's also a balance too. Like you don't want to be super over eager that you're
Right.
constantly like in the way, right? So just know your limitations and then also read the room, I guess your best thing to say. If it's a busy day, hang out, slow down, and help in other ways. You overhear a patient needing a blanket, go get the blanket. So then it shows that you're not below doing any job. You can do everything. And so you're a
Right.
team player.
That's really helpful advice. Dr. Mehta, do you have any thoughts on that?
Yeah, I would say same when you're on your rotations, just show them that you're a hard worker, but also that you're normal. I feel like in emergency medicine, all or most, obviously, the majority, they're just down to earth. You don't have to prove how smart you are. You don't have to be boastful. Just show that you're a hard worker and that you're normal. Like I said, in emergency medicine, you'll meet all different types of people from people who love sports to people who love music or whatever. There's a huge range of people and they're all like super down to earth. So you want to show that side too. You want to show like your real self. They want to make sure that you're the type of person that they could see themselves working with for the next 3, 4 years, however long the residency program is. You don't you, Be eager, like Allison said, but don't be overly eager because they can pick up on that too. Oh, they're just trying too hard and it's not really their real self. So just be yourself. Show that you're just like a regular person. You're easy to get along with and you're helpful. And when especially when you're on the rotations that have residents, don't hover over the attendings. Interact with the residents and just be as helpful as you can. Yeah.
You guys touched on something really interesting. I want to ask you a follow-up question on that. I feel like there's some unspoken rules about, and it's so hard to find that balance, right? I'd love your guys' take on this. It's so hard to find that balance of showing that you really want to be there, you want to work hard and stuff, and at the same time, being able to build a rapport with, especially the attendings or the PDs or the residents. Do you guys have any advice on how to conduct yourself? The unspoken rules of things that are just like, okay, no, I saw that as a resident. I'm like, no, don't do that. Like what medical students do, or things that medical students have done, and you're just like, I kind of want to work with that kind of person as residents. Do you guys have any take on that? And Dr. Mehta, would you like to?
Yeah. So like I was saying, so you're gonna have shifts with different attendings. Most of them, if they're in the academic side, like my PD, I think he may work 2 clinical shifts a week, probably one a lot of the time. So the people that you're gonna see the most are the residents. So
Mhm.
I would say make a good impression on the residents because the PD, he's not going to be there every day. The APD is not going to be there every day. But when we have our conferences and we have our meetings, they ask us, oh, which med student stood out to you? Who did you
Oh, really?
like? Yeah, they do.
Hmm.
Alice can speak to her experience, but at my program, they legit ask us which students were helpful, which students were not so helpful. Who do you think would be a good fit here? And that's not just during the application cycle. That's like throughout the year, we'll get these questions about feedback about the students that are rotating. Obviously, make a good impression with attendings, but you're going to see the residents more because we work a lot of shifts. Whereas, like I said, the leadership, they work some clinical shifts, but they're not there all the time. The residents are there all the time. And all of us are able to give our feedback on students that we interact with. So it is important.
That I actually didn't know that they would ask after conferences and stuff like that. That's really helpful. Just Spice, would you like to add to that?
Yeah, for sure. Our program doesn't necessarily ask too much, but if you feel like I'm the type of person, like if I really liked an applicant that was hanging out with us, because we usually have lunch after they have interviews, because we're doing some in person and some virtual, or even if we did the virtual meet and greets that I've gone to as well, I'll speak up and I'll go and I'll talk to the faculty that are like the APD or PD and say, oh, I really so and oh, I really like them, and etc. Or they reached out to me and ask me a few questions about the program. That's pretty cool. I'll say that.
Mhm.
But they don't really, or at least with me, probably because I'm an intern, they haven't reached out to me directly.
Mhm.
Whereas definitely I can see that they ask the seniors and the second years because they're more a part of the interview process, like as far as speaking with them on interview day. But for me, no, not they haven't asked me. But I give them my 2 cents recently.
Yeah, when it comes to med students, I just feel like a lot of people might want to know this. When it comes to med students that you guys and your fellow residents do gel with, is it mainly their personality that stands up to you, or is it kind of like you see them working hard and you're just like, okay, I really saw they put effort in? Is there anything in particular that kind of catches a resident's eye that they want to bring it up to the PD? Dr. Spice,
I
if you
think
want to
it's
just expand.
yeah, I think it's the more the personability. It's one
Okay.
personability, two, the genuineness of what questions they're asking, and three, sometimes I feel is like how at ease they seem already being there in the program. Like they feel like
Mm,
you can sense that they feel a calmness about them, that they feel like they already fit within your program.
yeah.
It's hard to explain, but you can sense it. And then I find like some of the students that come through, and some of them just know exactly what they're doing, like very educated, very intelligent. And you're just like, wow. I'm just like, oh, they're really smart. I'm impressed. You know what I
Right.
mean? It's not necessarily things that I don't think of. It's just thinking I try to think back on what I was like as a student type idea. And I'm like, I don't know if I presented that way or not. Or did I seem like that as like a med student too? I don't know. Maybe we do. We just take it for granted because we're so scared in the process and so anxious and nervous that we don't think that's how we perceive, but maybe we are perceived the same way as well. But definitely I think it's a personability thing because that's what we're really looking for in emergency medicine. Is their personality going to fit with the rest of us?
Interesting. Dr. Mehta, would you like to expand on that?
Yeah, same. I think I had a med student the other day that I really enjoyed working with, and they just had a good personality. It really didn't I didn't like quiz them, or I actually don't know how smart they are, how well they did on any exam. It's just about they worked really hard on the shift, and you can tell
Mm,
they were interested. You could tell they were interested in seeing the patients. Because in my hospital, I don't know how it is with Allison, like the med students are standing. Oh, they
mm,
don't really, it's busy. There's really no place for them to sit. But you can see my track board of patients, and they would like be paying attention to it. And they would, oh, I see there's a new patient. Can I go see them? And so just taking initiative and just joining into making yourself a part of the team. Yeah. So it's really a lot about initiative and just being helpful, whether it's just because sometimes patients or family, they'll just come to our desk and they're like, oh, can we have water? Can we have a blanket? Can we have this? Can we have that? And those little things, med students, obviously you'll be able to do more suture, whatever, chest compressions, whatever you want to do, be able to do more. But it's the little things that you're helpful with too. Oh, I'll bring you the blanket, or oh, I'll grab
mm.
you some water if it's okay. Those types of things are really helpful, and we pick up on it and we see because you don't have like this, or I'm too good to do the little things type of attitude.
Right.
So though we know those characteristics are really good for the team. So
Solid, really helpful. We're in our last few 10-ish minutes, 10, 15 minutes. Whoever has more questions, there's a few here still, but if you guys do have questions, just throw them in there now. Another question we have from the audience, what advice do you have for managing burnout during residency? Dr. Mehta?
so with our program, we have a lot of wellness events. Like here, we went to a Yankees game. We have like nice dinners they have for us at really fancy restaurants. So we do get our breaks. They do want us to not get burned out. It's tough though. You have to be realistic when you're coming in. You're gonna work a lot of hours. You're gonna have it's a lot of pressure. But as long as you can manage your expectations, just for this season in my life, I'm gonna have to work hard. I'm gonna have to push through. You'll be fine. And then when you do have your days off, totally decompress. Don't as much as you can, don't think about work or do something fun, do something you enjoy, connect with your family, friends. And obviously on your vacations, take that time, like go on a trip, totally step away from emergency medicine and do other things in life that you enjoy. So yeah, just have realistic expectations once you start, and then when you're in residency and you have your free time, your days off, make sure you're connecting with your support system, and then you're actually like stepping away from the job. Like I said, I'm on pediatric ICU right now. I am going to study for part of the day, but I was able to do this in the morning. And this is something that I enjoy. It's a way for me to pay it forward and give back. You're not going to have a lot of free time, but you can manage it to where you have time to do these types of things or do things that you really enjoy outside of medicine. It's possible, it's doable. You'll be okay. And then once you get your attending level, you're gonna have so much free time and you're gonna make the big bucks. So it's worth it in the end. This is just a short season in your life. So
Motivational. Dr.
mhm.
Spice?
Yeah, definitely burnout is a huge thing. I definitely think that burnout is, I don't know, like with me, I'm at that I'm only 5 months in. And so for me personally is I'm still excited. Yes, I'm tired, but I'm still excited to go. I'm so eager to learn and I find it so energizing, especially when I feel like I have a purpose and I feel like I'm helping people just the way I am. But that being said, is that the most I have right now is when I'm on emergency medicine, my actual EM rotation in the ER is that I go on 6 nights. And it's pretty cool with our shifts. So we have 8 hour shifts, but we have 2 hours of cleanup time. So 10 hours in total. But so every time, every month after those 6 night shifts type thing, I always book myself a facial and a massage. Always.
Oh,
Like
nice.
right
Very
after.
nice.
And so it helps me to like decompress and everything. And as far as with that, I wish I can get more time into exercise. I think that's the thing that I'm craving right now is I think I probably would be a little bit better if I would be able to get out and do a walk, but you are exhausted, you are tired. But I don't know. It's just something that it's almost done, and it's the first year, like for any program, is hell, and it will get better. And that's what I just keep on staying positive, and eventually I'll be able to sleep. But for those who know about being as a mom, that you're just so used to not sleeping anyways, right? So you just chug through, have your energy drinks, your coffee. Like right now, even me, I have an energy drink, I have a tea, and I have a Starbucks coffee for my day.
Being a mom prepared you for EM.
Yes, exactly. In a way, it definitely did.
Solid. All right, guys, in these last 10 minutes, if anyone wants to personally ask any of our panelists a question, there is a raise hand feature. If you want to go ahead and speak to the panelists, if you look on the bottom, there should be a raise hand feature. If you want, you can just raise your hand and I'll unmute you if you want to directly talk to the panelists. I did leave a few questions in the Q&A just because I think they might be better suited for later sessions that we have today. So again, if you want to ask directly to the panelists, raise your hand. I'll unmute you. But until that time, if there's no other questions. I think just one thing I want to know from each of you before we end our morning session. What was your favorite shift so far from when you started your residency to where you are right now? What was your favorite shift that you had and what did it consist of? Dr. Spice, we'll start with you.
Yeah, I would have to say my favorite shift is definitely I love the day, the 6 to 4. I don't know why, but I find it's a great way that one, it's dark when I leave the house, but it's bright and sunny when I come back. So definitely is that's what I really enjoy. A day shift too, it's different in regards to what the accessibility of the hospital is. Yes, it's really busy, but you just have your resources. So everything can happen a little bit quickly compared to night, whereas you might be waiting for a CT read, MRIs don't get done, etc. So I find one, like we all do, and we all have our favorites who we work with. So one, it would be like with one of my favorite senior residents that I would work with. Two, it'd be like also one of your favorite attendings that you would be working with, right? And then your nursing staff, it would be like your nursing staff, like some of the people that get to know you and you know them. It would be those three things were aligned would make any shift. It doesn't matter what time that shift would be, but those things is what really makes it enjoyable to be at work.
Solid. How about yourself, Dr. Mehta?
I would say for me, I recently probably had a really good shift. So last year, I feel like my intern year, I was a complete white cloud. So I feel like all my patients were pretty healthy. Obviously, I saw some high acuity stuff, but compared to my co-residents, I felt like they were getting all the exciting procedures and all this. So this year, second year now, I'm halfway through residency. I feel like my second year, I've become a black cloud. So I've been getting a lot of procedures. So recently, I had a shift where I intubated multiple people, put in a central line, I did a lumbar puncture. This is all in one shift. So
Whoa.
like, yeah. So like I intubated two people, I put in a central line, and I did a lumbar puncture. So like that shift was memorable. It was crazy. It was super busy, high acuity. I love the really sick patients. Obviously in EM you see a spectrum. There's people that come in for their runny nose, and then there's people who come in and they're dying. So my favorite types of patients are the really sick ones and the ones that need procedures. They're coming in, they're in respiratory distress, and I have to tell them, we need to intubate you to save your life. Those shifts where I get to do those types of things are my favorite. And recently, so this was in December before I went on vacation. December was crazy. We had so many sick patients, so the acuity was crazy. And yeah, I love the busy procedure shifts.
Oh, exciting. Both of you guys. Thank you for that. If anyone has any questions, now's the time. You Oh, I think someone's asking in the chat for the link for Clinician Nexus. So what I'll do is I'll get the link and I'll post it in the chat later on. So once I get the link, I'll post in the chat for Clinician Nexus for whoever asked that. All right. Otherwise, any other questions? Yeah, no worries. Awesome. Thank you guys so much. We have Dr. Allison Spice and Dr. Mehta. Are you guys okay? So I think you guys are. If someone has any questions for you, are you happy for them to send you an email or something like that? I see up here that you put your email up. I don't know if everyone can see it though.
Yeah, I'm putting my email there, and I think it's only going to either you or just
Okay.
me and
So
Allison.
yeah,
Yeah.
in that case, I'll put the emails up for both you guys just in case you guys have any questions. And Dr. Spice just sent the link. I'll put that up as well for everyone to see. But Dr. Mehta, Dr. Spice, thank you guys so much for joining us early on your day off. Dr. Mehta, taking the time out of your while seeing patients, Dr. Spice. This was super informative. Great start to the symposium. We really appreciate it. Thank you guys so much for being here.
Oh, thank you guys. And yes, anybody reach out. Don't feel like you're bothering me. Reach out as far as anything. Also, if you feel like you want to share my phone number as well, that's fine. Feel free. It's a Canadian number. So if anybody wants to WhatsApp me too as well, feel free. Just say, hey, I saw you on AAM webinar so that at least I know who it is and not a spam.
For sure. Will do.
Yeah, thank you for having me. I really appreciate the invite. You did a great job hosting, and I'm hoping that all the students and all the people who are online, they were able to learn something from this. And again, yeah, you can reach out to me too. He has my email, so you can share it with them.
Sure. I'll put both those emails and your number, Dr. Spice, in the chat right now. Thank you guys. All right, so we'll take a little break now. We have another two sessions for today. We have our next session starting at 11 a.m. EST, which would be 10 a.m. for those joining from Central Time. That will run for about an hour to an hour and a half as well. And then right after that, we'll take another very short break. And then we'll have a session, a Q&A session with our assistant program directors and program directors. That will happen at 12:30 EST, which would be 11:30 Central Time. Looking forward to all you guys joining in. And we're going to go ahead and take a little break now. And I'll put the contact information for Dr. Mehta and Dr. Spice in the chat. Thank you guys.
Great. Thank you so much, Musab.
Thank you.
I'll leave some of my information in the chat as well, just in case if no one feels like comfortable or can't come up with a question now and then wonders later on, oh shoot, I wish I would have asked that. Emergency medicine, how do we get here? For me, emergency medicine was my most intimate. It was the field I was most like intimately acquainted with. I would like a lot of people. I had done some EMS earlier in my life. I ended up actually in a career that had nothing to do with medicine afterwards. I was actually working in running bars and restaurants in New York City, working as a cocktail bartender, working for a big liquor distributor company and doing events for them. So it was a very shift work based environment, very fast paced, lots of different people, lots of different walks of life, getting to know what people wanted really quickly, having to be on your toes the entire time, having to be paying attention to like a whole swath of people behaving in appropriate and inappropriate ways. And it felt like when my natural environment, the ED, if you don't know, can be very much like that a lot of the time. So it was where I gravitated towards pretty quickly. It's also a place where you get to actually see results, do things with your hands, not only engage with people in the short term, but get to know them very quickly. You get to actually have meaningful impact in front of you for them. Oftentimes, you can actually make them feel better right away. You, from what we lack in having that longitudinal relationship with that a lot of physicians benefit from with patients, we do get a lot of great short-term outcomes as well. And then also resuscitating and stabilizing a critically ill patient can be incredibly rewarding, satisfying, exciting, and challenging at the same time. There's a lot to offer that emergency medicine can do a great job providing.
That answer just made me even more excited. Dr. Carvey, what about yourself?
Yeah, sorry for the absence of camera, guys. I'm just currently at a ski resort and my video came across as very pixely. So we'll go with just the audio for now. But I guess I'm more of a non-unique experience when it comes to deciding if I was doing emergency medicine or not. I came from a EMS background, just like Aria. I was a flight paramedic for a few years, and I knew I wanted to do emergency medicine right out of the gate going into medical school. So it's all about setting yourself up for success when it comes to applying for an emergency medicine residency. They want to see a longitudinal path of, oh, that's interesting. You did this, but how does that apply to emergency medicine? When you're doing your interviews for EM, they're going to ask you those questions. What kind of distinguish this specialty from another one? And that's not so much to say that you need to choose emergency medicine right now. Let clinicals guide you what specialties are most inspiring to you. But I was very biased in a sense that I knew I wanted to do emergency medicine early. And so that's where we ended up going. So.
It's solid. Yeah, so it's interesting you both had an EMS background. Was it like when you guys were training, doing your EMS background, what was it particularly that made you want to go all the way back do the grind of med school, residency, applications, all that stuff? Like, what is there an experience you had with an emergency medicine physician or something that might have happened on a shift where you're just like, okay, I want to go all the way back and do this to the point where I become an emergency physician?
I can go first if you want, Aria. So when it came to being a flight paramedic, I'm originally from Canada, so definitely like a foreign IMG applying to the States. You almost reach a pinnacle of how much you can do for a patient. So going from paramedic to flight paramedic, sometimes some people consider being a nurse as well before going into medical school. You reach this very frustrating peak of I can't do any more for this patient because I've reached how much I can possibly do with my scope of practice. And so that got really frustrating for me as a paramedic, which is ultimately why I became a flight paramedic. And then that got frustrating, which is why I became a tactical paramedic. And then that's got even more frustrating. And that's why I ultimately decided to go to medical school, because that's just, you're going to do the most for your patient by being a physician. And that's not to say that the other areas of medicine don't contribute to the patient as much as a physician does, including nurses, paramedics, RTs. Everyone is a team in this. It's just I wanted to be the one that had the knowledge and experience to be able to take care of a patient adequately and to the most that I wanted to do. And so that's why I ultimately decided to pursue medicine after going through all of that, because of the frustration of reaching a scope of practice that was at its peak already. And you really don't experience that you experience it in the emergency room, which is ultimately why I decided to do a critical care fellowship too. And I think Aria is probably along the same lines too.
Yeah, I'm happy to piggyback off of that. I just had to add a head shake at the very end for Matt. I think he's right on the money. I think the EMS experience, it's low-hanging fruit when you're very early career. You have an interest in medicine. You may or may not know what you want to do. Matt had a plan. The plan may not have had where he is now in mind in the very beginning, but every step he took, he had another step ahead that he was prepared to take that ultimately led to this eventuality in one way or another that this is what he wanted and needed to care for his patients. Mine is a little bit different. Mine was a lot more of a completely unbiased, unguided introduction. I fell into it. It was a couple of people doing it that I thought were cool when I was in high school and said, "Hey, why don't you come ride along on the ambulance?" And you ride along on the ambulance, and it just so happened to be a busy district and oh, Friday night, holy moly. I was like, what is going on here? You guys do this? And I was addicted. So I kept doing it. And then I needed to pay bills, and then life started becoming a little bit more challenging, and I became an adult, and it wasn't as convenient to volunteer and be on the ambulance. And in that time, I had become like a critical care EMT. It's like a level that kind of no longer exists, closer to EMTI at the national level now. And so I had spent a lot more clinical time in the emergency department than like a regular BLS EMT would. Not anywhere near how much time Matt has spent with physicians and clinicians at various levels, but I did get a little extra exposure compared to my peers, and those interactions were really formative. Those are the ones that when I fast forward, not to age myself, over a decade, I kept on revisiting when I was making my pros and cons sheet on the different specialties that I had in mind. Those interactions are really meaningful. The things that stick with you, the things you remember, the things that wake up in the morning and you have a revisiting dream of something happening, there's some weight to that. And so I think that having any exposure doesn't have to be EMS, but EMS probably biases you a little bit towards this field in general. That being said, a lot of what we do in the emergency department, it's a mix and match between other specialties as well. So you're getting to do a little bit of this, a little bit of that. I'm not thrilled by the jack of all trades motto because I think that we are master diagnosticians in the emergency department as well as resuscitationists. But that aside, we're very procedural, we're very decisive, we rely heavily on our gestalt as well as appropriate diagnostic choice. There's other fields that do that too, just at varying degrees. So the EMS exposure is patients from I called an ambulance to because I stubbed my toe to the resuscitation or the traumatic arrest that's not going well. And so I think if that's something that you're exposed to and you enjoyed, that narrows down a lot of the things that you may consider doing for a career after medical school. And ultimately, any exposure is good exposure, but I think EMS is great for people that have an interest in emergency medicine. I think they have a degree of natural progression built in.
Yeah, no. And I feel some students are going to be, or attendees are going to be listening to this, and they're probably going to be asking their next question as, what if you don't have an EMS background? Is that something that when you guys were going through interview season for residency or just even with colleagues in the application process, is it frowned upon? Is it expected almost to have an EMS background, especially as an IMG that's applying for emergency medicine, or are programs a lot more willing to look at other things as well, if you want to answer Dr. Z?
I can take that one, Matt. Yeah. Short answer, no. No requirement, no expectation. I'm not sure that it matters in terms of the specificity of EMS. You're going to hear this over and over again. You need to have experience that can illustrate motivators that are driving you to apply for a certain field. I very well could have been a volunteer on the labor and delivery floor of a local hospital and saw that every so often, really unfortunate late term pregnancy with a major complication that ended up in the emergency department. I could have been doing that and say, oh, that one time that I had to run down to the emergency department with the labor and delivery team to meet a patient and get them upstairs quickly to labor and delivery was really formative. Something that really stuck with me, seeing how all the different pieces and specialists were working together in the emergency department and getting somebody upstairs. I'm making this up off the top of my head, just as an example. So I think you just need to have experience that can illustrate why your interest is where it is. There are so many different things you can do. You also don't need to have done anything related to emergencies whatsoever. And that could be why why emergency medicine is attractive to you. It's okay to do something that you're not familiar with. No one is a doctor until they become a doctor.
That's true.
So you have no clue what you're getting yourself into until you start on day one and you're going, oh, whoa, okay. Even through your fourth year of medical school, the tinted glasses come off very quickly. And interviewers know that, residency folks, admissions folks, everybody knows that. They just want to see and they want to be excited about you being excited,
Mhm.
I think is the best way to describe it. And having EMS as an example in your toolbox just makes it easier to communicate that
Yeah,
in certain ways. That's all.
understood. Dr. Carvey, anything you'd like to add to that?
Yeah, I agree with everything that Aria said. You do not need EMS experience to be a good EM doctor. I will say, though, that you need to do something to distinguish yourself,
Mhm.
especially as an IMG, especially as a foreign IMG. Because if you don't have that thing as a talking point, you're just going to be like every other applicant. And it's sad to say, but most of the IMG applications, especially to major academic centers, get thrown to the side. So you really need to have something that distinguishes you as a person and you as an applicant. And that whether or not that's getting involved with AAEM RSA, that's what Ari and I did. That's how we got to where we were. And it's connections. It's who do you know that can vouch for you, that can get you an interview. And once you've got that interview, then you're just like every other applicant at that point. That's how I got my interview. That's how Aria got his interview at these big academic institutions. So do not need EMS experience, but you do need something that distinguishes you as an applicant.
Interesting. Actually, that piggybacks off another question I wanted to ask you guys. Both you guys got into very competitive residencies, as we mentioned a little bit earlier. Dr. Carvey already mentioned something about connections, but in general, if you had to lay out a plan for, let's say, a third or a fourth year, whether it's US IMG or non-US IMG, that they want to be at a competitive program like you guys are, what would you tell them in terms of if you were in their place again, third year or fourth year as an IMG, how would you get to where you are in a more efficient or a smoother manner? What would you say if you want to start, Dr. Carvey?
It's a really good question. I think if I was to go back in time, I would probably do exactly what I did previously, but I would try and make more connections at in a larger geographic area. I was
Mhm.
very focused because my wife had matched in a certain hospital system, Metro Health System, which is where I
Mhm.
wanted to be. But you can't put all your cards in one place as an IMG. I think we all know that at this point.
Right.
So if I was to go back, I would say being involved with RSA is the best thing I could have possibly done as a
Mhm.
medical student. And I would really get involved with something that you're passionate about within RSA or any other EM institution that you vibe with. It doesn't have to be just AAEM, AAM, RSA. It can be ACEP, it can be ASAEM, it can be any of them. Just make sure that you're doing everything you can to bolster your application and make connections. The connections are the biggest thing for IMGs and your SLOEs, obviously. But if you don't have those connections, no one can vouch for you. And that's just unfortunately what we need to do as IMGs.
What's your take, Dr. C?
Yeah, I totally agree with everything that Matt said. For some more specifics, so leadership roles can be valuable. I think that if specifically Matt and I both held leadership roles and still do to varying degrees at AAEM, RSA, for example, and also among other things that we've done. Both of us have very diverse resumes. The EMS one is a line items are bigger on his than mine, but both of ours are quite long because we both have a habit of saying yes. So that's a really good habit to have as an IMG. That has never hurt me professionally. Oftentimes physically or emotionally, sometimes it might, because might be scratching your head wondering why you signed up to go through patient charts in the middle of the night to be a 50th author on a paper. But it's a habit nonetheless that will get you further because you need to be proactive. It's unfortunate, that's the reality, but it is what it is. Being in leadership positions, I think, is so valuable because it demonstrates the same qualities that residency leadership wants in their folks. As a physician, no matter where you are, no matter what specialty you're in, you're the leader of the team. Even as a resident, the attending is not always in the room, but you are. Everyone at the end of the day, or when there's a change in something going on or an answer needs to be given right away, no matter what specialty you're in, if you're the physician and you're in the room, you're in charge, and leadership skills will benefit you and they'll benefit the patient because demonstrating clear, effective communication and decisiveness is valuable in almost every field. And they're also the same traits that effective leaders demonstrate as well. And having and holding those positions, and that's not to say that you need to be in leadership in AEM RSA. You can be the leader of your emergency medicine club. You can be the leader of a group that does community education or teaches CPR, name something. But being involved is one thing. Being integral to the success of an organization or an idea or a process or a project takes it to another level. And I think that's really valuable. And then it in turn makes it easier to network because then you have things you can talk about. I've been in the same position where I've gone to these conferences earlier in my first and second year of medical school, and I want to shake hands and meet people, and I'm going, I don't know what to talk about. I don't
Yeah.
know what am I going to say? How are these people going to remember me? And have it be good memories.
Yeah.
And having interests that connect professionally and engage in leadership activity makes it easy. Just talk about that and then let whatever networking conversation you're having just go with the flow. But as a third or fourth year, you need to talk to everybody. You need to ask
Yeah.
people, do they like where they are? Should I apply here? If so, who else should I talk to that's at this program? Is there anybody in leadership that you think I should speak to? How do I demonstrate my interest? And you can nag them. I would say do not do that for everyone. Get a feel for the program. But if you really want to be somewhere, don't be afraid to tell them. Oftentimes they want that. I've heard multiple program directors say, I got the sense that this person was really interested, but then they disappeared or they didn't email
Really?
me again or lost a follow-up. Persistence pays off a lot of the time. And that's another valuable trait as well. Don't be a nag, but being willing to put yourself out there will help you in the long run, and it'll make people want to help you when you're open and honest.
Yeah, no, I'm taking mental notes of everything you guys are saying right now. This is very helpful. And we're definitely going to be talking about networking in a little bit because I feel that's something that a lot of students, especially med students, want to know. There is a few questions from the audience. Just wanted to get those before I move on. Someone's asking, they hear a lot about cracking the interview and they need to stand out, but they want to know, what do we need to do right to get an interview in the first place? Like you said, IMG applications are going to be thrown aside immediately. Other than networking, is there anything I can do to make that happen? I'm assuming they're probably referring to programs that have cutoffs, whether it's step two scores or other things. In your guys' experience, is there anything someone can do where they don't have their application thrown? If you want to start, Dr. Carvey.
Yeah, so I can speak to our program, and then Arya can speak to Yale as well. Our program didn't start becoming IMG friendly in quotation marks probably up until I applied. I think we had one other IMG at the time. The only other way that you get your foot in the door is one, I have to repeat networking again, because that's the only way I got an interview at this place. I think other things that you can do is join these webinars that SAEM holds where they're doing residency talks specific to programs, and go to those, because a lot of times it's crazy, but a lot of times these residency like talks that specific residencies are doing, not a lot of people show up. And if you're the one person that's there and they're doing like 3 talks, you better be at all 3 of those talks if you want to go to that residency program. So SAEM holds one of those medical student seminar things, I think, before you apply for the match. And I can't remember what it's called. Maybe Aria knows. But I went to all 3 of them for Metro Health Cleveland Clinic System because I knew I wanted to be there. And it got to the point that they were messaging me and being like, you were the last one, weren't you? So it's just,
No way.
yeah, you really have to be persistent with these things if there's a program that you really want to go to. And once you are persistent without being annoying, it gets to the point that they're like, oh, this person really wants to be here, just like Aria said. But you really need to have people to vouch for you. You really do. Neither of us would be where we are without that. And the only way that I was able to even start with AAEM RSA was obviously by joining. But I started with the wellness committee. That's where I got my foothold in AAEM RSA, was joining the wellness committee. And then eventually you work yourself up to chair. And then from there, you make yourself more visible to other groups. And you make a more impactful experience for yourself when you're talking with these larger people that you eventually want to become. So mentors are another huge thing. Ari and I are obviously very happy to be mentors for anyone that asks. But like he said too, most times I would say 90% of the time that I have a mentee, they get lost to follow up. I message them and they're gone. And that's the last thing you want to do as an IMG who wants to get into a competitive program, is be lost to follow up. I would say, to sum up what I said before I pass it to Aria, is networking is the biggest thing you can do. Take whatever you can get with what you're offered to get yourself a foothold, and then join all of these webinars that programs are doing, because a lot of times there's just not a lot of people that show up to them. So you can definitely be persistent that way too.
I'm actually writing down some of these things in the chat because I feel like this is really helpful. It's a lot of things that I know I've asked a lot of advice, but I haven't heard some of these things, especially like the insider take about being lost to follow up, or when someone thinks that they're being too annoying. At the same time, the programs, like you were saying, Dr. Z, is, oh, they just never got back to me. I feel like it's really interesting to know. Dr. Z, if you want us to add in anything to that as well.
Sure. Going back to a part of the original question, you mentioned scores and
I guess that's
more
a component to the original question, yeah. Yeah,
yeah,
more like not
granular
getting your
items.
Yeah, like not getting your application tossed. Is it scores? Is it what makes your application seen?
So if you do not have the scores that you know you need to have, whatever they may be, for whatever it is that you want to do, wherever it is that you want to go, because you'll have some idea. At the end of the day, we never really know exactly what's going to make or break, but there's usually a window. And if you fall outside of that window, that makes the things that we're talking about right now, things that Matt especially just discussed, non-negotiable, because your application will not see the light of day if you don't have what you need on paper and you have not made the effort to make the connection. And it's just as simple as that. It's unfortunate, but it's the reality. And that's the reality that you have to operate with in order to make the right decisions and be very proactive. all this goes back to being proactive, going to these webinars. That's a great thing. I ended up in one. I forget the name of it. I think it was one of the SAEM ones, and I remember I was like one of two or three people in the room with a program director, and I wasn't prepared for that. I thought I was going to be sitting there watching, so I was going, "Oh no, I'm like being interviewed right now." These are great things. And when you're in these environments, also be yourself. Don't try to be what you think they want you to be. You don't know these people. They just want to know who you are because they're going to be stuck with you for years. And they want to know that they're going to be stuck with a reliable, responsible, good, normal person. So don't pretend to be something that you're not when you are at these networking events. I think is also really important. And this may sound like really silly advice. Write everything down. Like everybody that you meet, write down their name, their email, and their phone number, whatever information you get, where you met them, what you talked about. Write all of that down because it gets dizzying at a certain point if you are being proactive and you're meeting all these people and you're having conversations and you're going, "Oh, I had that great, and it was a program Richard from here," or was it the one after that I had from there? And one is in California, one is in Iowa. Shoot, it sounds silly, but not being organized and keeping track of everything that you're doing can hurt you in the long run, especially as an IMG, because at the end of the day, it's a lot easier for your application to be tossed to the side. So having every T crossed, every I dotted is really important. And if you can say without a shadow of a doubt, we spoke about this. This was impactful for me. When you send like a letter of intent to a program that you really want an interview at, that you're not sure you're going to get an interview at, the details matter. That means that you were paying attention and you haven't stopped thinking about it. So taking
Mhm.
notes and remembering what you talked about, who you spoke with, and why that was meaningful to you, and why that informs your desire to be somewhere and train somewhere and learn from that person is really important.
Very interesting advice from both you guys. I do want to touch on networking. I think that's something that a lot of med students want to know more about. And I want to touch a little bit more of the soft skill of networking in general. So students, for example, they go to these events, but then they're in this position where they don't really know what to do next. People don't want to, like you were saying, Dr. Carver, don't want to be nagging or annoying. At the same time, they don't want to show that they're not interested. Was it a skill that you developed over time just by going to more events? Or was there like a certain state of mind or a frame of mind you have when you're going to these events? You're like, okay, when I approach this program director, this resident, here's how I'm going to conduct myself. Here's how long I think the conversation should be. Here's how I'm going to show interest without being annoying. Do you already have that mindset like set? If that question makes sense, Dr. Crawford, you want to start.
Yeah, it's a skill to be able to network. And it's not a skill that is really innate to a lot of people. When med students, even residents now, come up to me and ask me questions about how do I get into X, Y, and Z fellowship or residency, I think the ones that are most impactful are the ones that are easy to talk to. And what I mean by easy is you're listening to that person. Don't overtalk that person. Don't come across as overconfident or cocky. That is the worst thing you want to do for yourself because unfortunately, in the totem pole of medicine, I'm still very low. And unfortunately, a med student is even lower. And that's not meant to be, I'm not meaning that to be mean by any sorts, but that's just the way it is for
Right.
IMGs, especially. If you look at it in the method of looking at it as a totem pole, I think it just makes things easier because the people that you're talking to are eventually people that you hopefully want to be. You want to be an
Yeah.
emergency medicine doc one day. You want to be something else that's great. But you really need to, when you're networking with these people, make it short and sweet. Don't overtalk because a lot of times these individuals are usually talking to a lot of people, but make it impactful, like Faria said too. Write down their name, write down their email, and then at a later time, you send them an email and be like, hey, I really enjoyed talking with you about X, Y, and Z. I really wanted to get to know more about this, or are you doing anything that I can help with? And exactly
Mm.
like Aria said, you never say no. because the moment you say no, the moment I lose interest a lot of times too. Because if I'm
Mm,
asking you about something or I'm asking you if you want to join a project, it's probably beneficial to join it from an emergency medicine perspective. Even if you don't like the project, it's something that
yeah.
gets your foothold into something. That's what I mean by annoying, is just make it short and sweet, especially if you don't know the person, and look them up before you talk to them. Who is this person? How can I like make it a little bit more impactful when I'm talking to them? I'm like, oh yeah, you live in Canada. Oh, you're a flight paramedic. Oh, you went to X, Y, and Z residency. Like, how did you like it there? You got to have a topic to go into, because I've been in some really awkward conversations, and I remember those awkward conversations more than I do the good ones, unfortunately, and that just does not bode well for people. So that's what I would say for networking. When you're at a conference, initiate the conversation with that person. As intimidating as that's going to seem, that is what makes you stand out from the other people that are there. Because it's very easy just to go to a conference and literally just exist at the conference and
Yeah.
not get anything out of it. So always initiate the conversation with people that you want to talk to, and they're going to give you the connections that you need to hopefully have a successful career as an emergency medicine doc.
Super helpful. And how soon do you think someone could reach back out via email? And let's say that email gets ignored because obviously everyone's busy, especially EM physicians. Like, how often would you recommend them following up before it's okay, this person, now I'm crossing boundaries. I shouldn't be consistently nagging this person.
Don't email me the next day. Please, God, don't do that. Especially
Do
at a
not do that.
conference. Especially at a conference, because it's just, you're so busy at a conference, and the last thing I want to see is a bunch of emails that I now have to answer. I don't know, Aria, you can speak to this too. I think 2 weeks to a month after you've had a conversation is great, but even after that, it's really judge how often you can email this person just based on their response that they give you as well.
Okay.
Yeah, I 100% agree. That you actually, I've got an email the next day after meeting someone and at a conference, and we're so busy at the conference that I go, oh shoot, I have to email back. Okay, I'll do that later. Guess what doesn't happen? Because busy and getting flooded with emails, not coming back around. It's a 50-50. I go back through my inbox and I go, oh shoot, and I catch it buried. Oh, I forgot that I just met that person. Who was that per blah blah blah. Giving some lag time. Don't feel like you're being forgotten if you send an email 2 weeks after you meet somebody or have an engaging and informative conversation, and you don't hear back for 2 more weeks. And now it's been a total of 1 month since you met this person and have spoken to them. They're not ignoring you. It's not because they don't. It's very easy to spiral and say, oh, what was my email? Did the tone of my email sound weird? Did our conversation not go well? It's okay to give it some time. And it's also okay to follow up after some time has passed. If you don't hear back in 2 weeks, that's okay. I have emailed, I remember before application season got underway, there was a program director that I emailed who got back to me 3 months later and sent me the nicest email and was like, I'm so sorry, I'm catching up on emails. I read your initial email. It's been on my list of things to do is to respond. My goal was to respond before application deadline, and that's fine. It's totally fine. Just don't be a pest.
That's a common theme that I'm hearing. Now, in those situations where I'm sure students would want to know this, let's say they did mess up the first interaction. Let's say someone is trying, like a med student's trying to network with you guys. They butchered their first interaction. They were nagging. They didn't know. They were being too eager. They find out later on they probably messed it up. In those situations, is it recoverable? And if so, how should they go about things now? Should they start over, or should they just assume like any more I do now is just going to be annoying? If you want to start, Dr. Carvey.
Sure. I think actually Aria is probably going to have a better answer than I will. But when it comes to reaching out again after that
What does that mean,
interaction,
by the way?
oh, I'm curious to hear your answer for this. But when it comes for me personally, it comes down to, if the first interaction didn't go well, I may remember it, but if you email me at the appropriate time 2 weeks later and you're like, hey, like we had chatted about this, I was just trying to express my interest in this is what I was interested in talking with you about. If you're interested in becoming more invested in the critical care core, or you want to do some research in something that, we're currently doing, and you start out the conversation by, hey, I want to be an author on your paper, that's probably not the way to start it. But if you reach out again and say, hey, I was really interested in a project that you're doing, how can I get more involved with this? That's just a really good way to approach things, because then they're like, oh, I can get you involved in any way possible with this project. And you're not looking necessarily for authorship on it, but down the road, these people are going to want you to be involved more and more, especially if you prove that you're contributing to whatever that you're trying to aim for as well. Ario is a prime example of this with the crit care course. He came in and he had a lot of ultrasound experience previously and has now become a very integral part of this course, to the point that he is now lead instructor for the ultrasound portion. And so it takes persistence with these things. If you started the conversation and it's awkward and it didn't work out, then try and approach it a different way. Just say, how can I help, instead of being very specific about something, because it's what you need to do until you get to know someone a little bit more personally.
Interesting. Dr. Z, what do you think?
I don't know. First, I have to ask Dr. Carvey over there if I was a nag.
So he actually came across initially as a neg. No, I'm just joking. But Aria was very persistent, and I had never met someone who was as persistent as him, but he did it in an appropriate way and wasn't annoying about it, I think, is what it initially, I guess, it came down to in the end.
You have to show interest, and it needs to be genuine. It's very clear when everyone knows that you are driven by a set of factors that are somewhat out of your control. Like, you need to have things on your resume. You need to have things you can talk about. You need to have things that help you stand out on your applications. And that's a fact. And that can be annoying internally as well, because you're always fighting this battle of, oh, I'm interested, but how interested am I? Am I pretending to be too interested? That's how you end up in awkward conversations. That's how you get yourself into these situations where afterwards you're going, oh my goodness, I think that was a great opportunity, but maybe I was a little too one way or the other about it. And that's okay. Just like Matt said, following back up and rejiggering the conversation and saying, I had time to think about our conversation. This project actually really interests me. This thing that you're involved in really interests me, X, Y, Z, Y. If I came across too eager, that's just because I'm really passionate about this. And then illustrate that in words. We've all been in the shoes. We're all human. It's okay to feel like you bungled a conversation because you were nervous or you overspoke another person. It happens. It's not ideal, but it happens. But being persistent and then clear with your intentions and follow through is a component that can make these types of things recoverable. Something that if I like something or I'm interested in something, I go to everything for that thing. Everything that there is. If there's a paper that gets released, I read it. If there's a new thing I can do with an ultrasound machine, I try it out on a patient or on myself. Being genuinely interested will help you end up in these positions where it's easy to have these conversations that don't get messed up in the first place, or things you can talk about in the back end. But showing up and saying, I dig what you're doing. This is really cool. Tell me more. How can I learn more? How can I be more involved? Over and over again is the easiest way to do that. It's not the personality test part comes like further down the line. That's what residency applications are for, an interview process. We're not interviewing you when, you're at a networking event per se. It's more of a testing the waters.
Understood. Very interesting take on things. I feel like that's something we don't really get to hear about too often. So I appreciate you guys' take on that. We did get a few questions in on the Q&A. I'm not sure if this question is a general question, but someone's asking about SLOEs and is that hard? So we need SLOEs, and even that is hard getting as IMGs, how to bag them. I'm not sure if they're referring to if they're like in a different country, like not in the US, maybe doing, if that's what the question is, I'm not 100% sure, or if they're just generally asking about SLOEs. But if you guys just want to have a quick comment for SLOEs, what's the best way for a student to achieve a good SLOE?
Aria, take it away.
Oh, okay. This there's a lot of components to this conversation. So first we have to talk about what a SLOE is. Or if I mean for the people that or if there's somebody in here that may not know what it is essentially your audition rotation. And it doesn't necessarily have to be the place that you end all be all want to train at and work at, but your experience there and their experience with you under their umbrella is going to dictate quite a bit about where you end up. They are looking, and when I say they, I don't just mean the big wigs and the program directors. It's everyone from the nursing staff, the residents, the PAs and NP, everybody that's involved in clinical care that you interact with has a chance to weigh in on what an excellent member of the team you have been, or what a poor contributor to the team you have been, and staunch opponent to success for patient care. That not, almost never happens, but there. So really, the more important idea here is how to separate yourself out from everybody else that wants the same thing as you and wants to be not only a successful applicant, at the end of the day, an excellent clinician and patient care advocate. So I think that going back to a lot of what we said already can be this can be very simple. When you are getting a SLOE, so a SLOE is a document that says that this person came and rotated at our organization for 4 weeks or so. They engaged in this type of patient care. They interacted with these different teams, and this is what we saw. This was our impression. So think about that. The impression. So it's not necessarily what you did, what you said, who you helped. It's how you impressed upon the people around you. And that can mean the world. And one way to illustrate that is it's okay to not know things. You are a fourth year medical student. When you are doing your audition rotations, it's very stressful sometimes to feel like there's some pressure to feel like you have to have answers. You have to be the star and rise above. It's okay to not know that. People are not expecting you to be an expert clinician, a senior resident, somebody who's going to make the end all be all decisions. They want to know that you're thinking about those things, though. They want to see your process. They want to know what your differentials are. They want to know why you came up with ideas. They want to see you being proactive and helping out the residents, the nurses, and most importantly, the patients. They want to see someone that's very obvious why they are where they are in their natural element. And that's something that is very difficult to fake. I'm sure people do it. I'm sure Matt's interacted with a resident or two in his day, either his institution or elsewhere, and that's not specialty specific. That I know I have. That some people are really good at faking it, but it's hard. So the impression that you leave upon the people that you interact with is probably the most important component of your SLOE. Now, that being said, if you get asked a question, and this is an important one, and this is a simple one. If you get asked a question that you do not know the answer to, you better go look that answer up because there is a high likelihood that you're going to get asked that question again. And if you did not go look it up and have a good answer for that question, guess what? That instantly says, I don't care, or it's not that important. And at that stage in your career, and even at the stages that Matt and I are in our careers, him way ahead of me, we can still not make that decision. So if someone asks me a question, one of my attendings, and I don't know the answer to it, and they ask me again the next day, and I still don't know the answer to it, that's problematic. That does not send a good message. Now imagine being someone who feels like their application is on the verge of being not looked at all. You damn well better do everything in your power to know that and more, as an example.
Very helpful. Very true. Dr. Carvey, is there anything that you wanted to add to the SLOEs topic?
Yeah, I think two things. First one being if you're an international IMG that doesn't have connections to US based hospitals for SLOEs, I'm not a great person to ask about this, but when you're looking for institutions to rotate at, it's just best to reach out to the program coordinator. They're always going to be on the EM website. Reach out to them and be like, hey, I'm so and so. I graduated from this medical school, or I'm at this medical school. I'm just wondering if you accept people rotating in your emergency department in order to get a SLOE. A lot of times the answer is going to be no, but you're going to find institutions that will say yes to that. Sometimes it's for a fee, which is insane, but you really need to get SLOEs, especially if you want to be in an EM residency in the United States, because if you don't have those, it's really hard to get an interview. Second, to speak to the point and importance of SLOEs, as soon as your interview packet isn't thrown to the side, the first thing our program looked at, as soon as you open that up, is the SLOEs. That is the first thing that we look at. And if we see any SLOEs that are unfortunately less than perfect, a lot of times they get knocked again to the side of the pack. And it sounds really hard to get a perfect SLOE, but I'm going to be honest with you. If you do the things that Aria said, you're not weird, you work really hard in the emergency department while you're there, you show interest, it is very easy to get a good SLOE. So you just really need to work hard when you're on those rotations, because if they get any hint that you're lazy, that you're not getting along with the residents, the nurses, the RTs, obviously the staff, even the caretakers and janitors, if I see you interacting like wrong with one of them, I'm going to put that on your SLOE. You need to be an expert while you're there and show the interest that you want that program to exhibit on that SLOE. Because Aria said, even if you're not applying to that you better be applying to that program. Even if you're not wanting to go to that program, in the end, that SLOE is going to carry with you and stay with you your entire application process. And if you have a SLOE that's a 1 out of 5 or whatever the scoring system is now, that is not good. I would say, again, just to summarize what I said, go into that rotation and show interest. Really, like if you're with a resident or with a staff that day, be like, hey, I really want to go and see this patient. Do you mind if I go and see them specifically? Don't spend an hour in the room. Spend like a good solid 10 or 20 minutes in there, like doing your thing, getting a really good physical exam, as much of a history of you as much as you think you can get, and then come back and present the patient in a way that you're confident doing. It's not going to be perfect. I don't expect for perfection for a history and physical exam from a medical student, but I expect you to get the basics. So if and this is another thing, if you walk into a room and someone is dying, you better come out of that room and tell someone, because that's another thing that shows that what the difference is between a sick and a not sick patient. And just the definition of being weird, just to expand on that, is you're just overconfident with things. You're either doing something on the computer that's unrelated to why you're there, and you're just way too confident in the totem pole of things, I guess, at that time. Just be yourself, interact with all of the staff that are in the emergency department well, and just try and do as good of a job as you think you can do. Work really hard while you're there. Go and see a bunch of patients, present those patients, do the workups that, the residents and staff tell you to do, and look up the things that exhibit that you're interested in being there. Because like I said, the first thing that we look at when we open up that residency packet is the SLOEs. So they better be good.
Really helpful. Thank you, guys. So as we're approaching the end of our second session, I'm getting a bunch of questions now. If you guys just want to send your questions in, I'll do my best to get to the ones that are relevant to this session in the time that we have left, which is the next maybe 10 minutes or so. So someone wanted to know, I resonate with the be yourself message for interviews, but to what extent does the interview conversation unfold as a genuine conversation versus a more scripted interview process intended on gauging student interview prep? So I guess they're asking, can you just comment on some basic ideas regarding how a student can best prepare, specifically for interviews?
Know everything that's on your CV. Do not have things on your CV that you don't know about. As far as formalities and how a conversation is going to go, it's going to be very variable. Emergency medicine is generally, we like to have informal conversations. We like to know people and get an idea for what makes them tick, what their interests are in and out of medicine. So it's not unusual to have a conversation where you show up to the interview and you feel like you're going to be peppered with 21 questions and they go, have you read an interesting book recently? And that can happen. And it's not meant to put you off. It's just meant to get a better sense for who you are. Because if you make it to the interview stage, they already know a lot about you. There's a ton of information about you that can be pieced together. They want to know who you are. Now, that's not to say that there are not interviewers that will be very run of the mill. They'll be regimented. They'll have a series of set questions. Some programs still do standardized questions, and those you need to be prepared for. But I'd say that those are in the minority from my experience, and that a lot of it has to do with knowing what your own background is, because that's what they're going to talk to you about, and telling the truth and being normal and being yourself. I don't know, Matt, do you have anything to add?
I'm going to give you an example of a good interview and a bad interview that I've had. So, starting with the bad interview and ending on the good, obviously. A bad interview that I've been in is someone who was applying for the second time, initially applied ortho, now applying emergency medicine, clearly as a backup, which is absolutely fine. They came into that interview so cocky. And you could tell based on their CV that they were very interested in ortho because they had a bunch of papers published in ortho, nothing really in emergency medicine. And the worst thing that person could have done for themselves has been cocky in that situation. Like when I bring up, oh, you've got a lot of publications and it seems like there are a lot in orthopedics. How are you going to translate that to emergency medicine? Like, how are you going to bring your interest in orthopedics to emergency medicine? Was the question that I asked them. And they were like, I'm not too sure. I'm probably going to stick around for a year and probably apply to ortho again. Wrong answer. That is a key example of what not to do during an interview. Being yourself doesn't mean being cocky. If that's the way you are as a person, then I would really try and humble yourself a little bit before going into the interview, which I'm sure none of you are, but some people definitely are. So that's the wrong way to do it. The good interviews that I've had are people who like walk in and they're just like, hey, I'm so and I ask them like run of the mill questions. Oh, where are you from? And they're like, blah, 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 blah. And if I'm having a good conversation with you, our program did do standardized questions and we had a piece of paper that we had to read off of. I usually scrap that piece of paper and I just want to know you. Honestly, that's how it goes. And if I'm having a really good conversation with you, that interview went really good. And the way to do that is literally be yourself, show interest in emergency medicine, but also specifically that program. Because a lot of times I'll ask you questions about, like, why are you specifically interested in our program? What is it that made you apply to this, and what distinguishes it from other programs for you? So you better know that EM program as well when you walk into that interview. And if I end that conversation after the 10 minutes that we usually have with each applicant, and you walk out of the room and I'm like laughing, that interview went really good. And I'm going to be honest with you, I would say probably 25% of the interviews go that way. So it's fairly rare for that to happen, unfortunately, which I want someone that I'm going to be able to talk to on shift, have fun in the emergency department, and just get through a really crappy day with someone I know that's going to have my back. If that's what we're basing the interview on, is if that's going to be the person that's going to be there. And if you're not that person, then maybe it's just not the right program for you. Other interviews may go better, but I would say just be yourself, but don't be cocky, I guess, when you go into it, or overconfident, I guess, is a better answer.
Awesome. Super helpful.
Just
And we'll
I'm sorry to interrupt. I just want to add, this is a perfect opportunity as well for an IMGs who all of you have come from like diverse backgrounds. Many of you have completely different experiences from traditional applicants or traditional US medical school applicants, for example. This is your time to shine and talk about things that separate you and make you unique. And that's a superpower. So just keep that in the back of your mind as well. The things that set you apart also can benefit you in a lot of ways.
That's a great trip. I think we have time for one last question. And I found this one really interesting. So I'll go with this one. So someone's asking, I'll read the long version, then I'll summarize it. IMGs already feel like we have to overcompensate for being IMGs, and we're always on our best formal behavior when talking to PDs, APDs, and attendings. If Dr. I'm not sure what they mean by this, but if Dr. Fossey says, call me Tony, okay, call me Tony, is it weird to do that outside of the ED setting, or is that some kind of test? I think they're essentially asking about professionalism versus building rapport, what the boundaries are, and how to do that without overstepping boundaries.
Yeah, that's an interesting question. So it's the whole I got to call you doctor kind of thing before I reach a certain stage of life, and now I can call you by your first name. It's going to vary person to person. You just have to judge based on that situation whether or not they're actually comfortable with you calling them by their first name. Usually in emergency medicine, if I tell you to call me Matt, then I want you to call me Matt. If you can continue to call me doctor after that, I'm going to continually repeat myself and say, call me Matt. But it's going to vary person to person. Always just be formal in the first place. Just refer to them as Dr. So, and you'll never lose by doing that. And if they say, call me Tony after that, then if you still feel weird doing it, then go ahead and continue to call them doctor. But if they repeat themselves again, just call them by their first name. They're clearly making a point at that stage they're comfortable with you calling them by their first name.
Yeah, when in doubt, always default to doctor, even with attendings that I have very long-term good relationships with. Even sometimes it say, hey, doctor, and they'll look at me and go, okay, what's up?
Yep.
And that's fine. But what Matt said, it's okay if they repeat themselves, then it's okay. And if it's not okay, they'll also let you know.
Perfect. Honestly, thank you guys so much for joining in today. I learned so much. I'm getting messages. Everyone learned a lot. There's a lot of unspoken rules we didn't know about that we learned about today. This was super, super helpful. Really appreciate you guys taking the time, honestly. And I did want to give like a little quick plug just for no one's asked me to do this, but the critical care course that they offer through AAEM is by far the best course, one of the best courses I've ever taken. So if you guys haven't taken it yet, highly recommend looking into it. But thank you guys so much for joining in today.
Yeah, thanks for having us, Musab. Really awesome to have all you guys interested in emergency medicine, and hopefully looking forward to see you guys in the future.
Thank you. Awesome. Thank you. So we're just going to take a little break, guys, and then we'll sign back in for our last session in about 15 minutes. If you guys have any questions, please just go ahead and put it in the chat, and I'll try to answer them during the break as much as possible. See you guys at 12:30 EST, 11:30 CT. Thanks, guys.
Good luck, everyone.
Good luck, guys.
Thanks, guys.
I do now. So I have a foot in the admin door with my assistant medical director role, and then I have a foot in the education door with my APD role. So.
That's amazing. Super, super excited to have you guys. There was a lot of questions people wanted to ask you that were sent to me outside of the webinar. I'll try to get through as many as I possibly can today. I did want to start off with just knowing, in general, a little bit more about both of your programs. So I know Oklahoma University, Baylor, both really high-end programs, especially for emergency medicine. Could you just briefly touch on, because we have a lot of applicants here as well, could you just briefly touch on what you believe separates your program from several others and why you enjoy being there? If you want to go ahead and start, Dr. Andrabi.
Okay, sure. So I'm still at Baylor. So I joke I'm a Baylor inbred. I never left, but Baylor's in Houston. So there's a few Baylors in Texas. So that's why I bring that up. But our program is in Houston, Texas, in the Texas Medical Center. We're a level 1 trauma center, our primary teaching hospital. There are 2 level 1 trauma centers in the city. For how big Houston is, there should be about 4, just to give you an idea. So you tend to get quite a bit of volume. Because we are county, we are definitely a gun and knife club. We see a lot of penetrating trauma there. And in addition to that, strokes, STEMIs, all that stuff. So very high acuity, high volume that you see. Big underserved population. About half our patients speak Spanish primarily. Majority of our patients don't speak English as their first language. A lot of them come in because they can't get access to care elsewhere. So you're dealing with acute emergencies, but sometimes you're also dealing with primary care stuff too through the ED because these are patients who can't get access to other places. We have other training sites that we work at. So the other one is St. Luke's, which is also in the medical center, high acuity, medically very complex patient population. You'll see LVADs and transplants there. And then we also train at Texas Children's, where you'll get a variety of pediatrics. You'll get your bread and butter there, but you will also see kids there with diseases that you read about in textbooks that you've never seen in your life. I've never called genetics in the ER, except when I'm at Texas Children's. So that's always a fun place to work. And then we work at some of the satellites with TCH2, like at West Campus and Katy. And so that's really nice because going out into the suburbs, you don't have as many of the resources that main campus does. So you learn to work in an environment where maybe you don't have all the specialists on hand. And what do you do then? And you learn to get very comfortable doing your own procedures and things like that. Apart from that, we are very service oriented at our program. So that's if you go on our website and you take a look at us, that's a big part of what we do. Not only service just in our hospital and kind of working in the county setting, but also out in the communities where our patients live. So whether that's volunteering at the food bank or we do school supply drives with our local public elementary schools, we volunteer in the soup kitchens nearby. So those are all big things for us too, is the service aspect.
Very cool, very exciting. Dr. Janik, how about yourself?
Sure. So OU Tulsa is a 3-year program. It's community medicine driven. So most of the people who come into our program are aiming to become community physicians. And so with that sort of focus, I would say philosophically, it's very much focused on clinical skills and trying to create the strongest clinicians possible. We are affiliated with OU, so we have all the academic resources of that. And we do have about a couple residents per year who end up wanting to do fellowship or go into academics. We try to skim the academic minded ones into our own faculty if they're interested in staying in Tulsa, but oftentimes they stay and oftentimes they will go to other academic jobs afterwards. But our main teaching site is a hospital called Hillcrest, which is technically a private hospital, but acts like a county hospital, which has on one hand some really high end stuff like LVADs, and it's a stroke center and it's a burn center. But then we also don't have ENT half the time, and we don't have optho. So you get this mixed picture of seeing some of these like really complex patients with this interesting technology on one hand, and then sometimes having to do the transfer process or understand what to do when you don't have the specialists for other kinds of things. And then we do away rotations at St. Francis and St. John, which are 2 Catholic hospitals in Tulsa, both of which are level 1 trauma centers newly and are bigger, more mixed urban to suburban type populations. And then the other thing that I think sets OU Tulsa apart is that being in Oklahoma, Tulsa is one of the 2 major cities in Oklahoma. And then about a third of the state lives rural. They live in small towns. And so when we're thinking about training people for Oklahoma, we are also very much thinking about training people to work in rural sites. And so we have longitudinal rotations where we send our residents to work in rural hospital. And many of them also moonlight. And when they moonlight, they will moonlight at the rural hospitals. So we get a fair amount of training working at these critical access places with 10 beds and 2 nurses. And it's you and them, and you get what comes in, which is sometimes urgent care and sometimes like really sick people who you're like, how do you live not in a major city? And we've done all sorts of wild critical care stuff in these rural settings. And so really the focus on excellent clinical training so that you can go work in these really resource poor settings when you're the only doctor for 50 miles around. So I'd say that's the big focus. We had historically been a very Oklahoma centric program because the mission of the university is to train people for Oklahoma. And I would say in the last 5 to 10 years, we've really started getting more applicants from outside Oklahoma and people being attracted to coming to live in Tulsa. And then also graduating people to the wider region, not just Texas, which I think has a lot of back and forth with Oklahoma, but also to the Midwest and to the Northwest and all different parts of the country.
Very cool. Awesome. Thank you guys. We'll go ahead and get started with some of these questions that we got sent in. So we have a lot of IMGs that are attending our session today. A lot of questions I got were regarding the application process. Essentially, to put it in simple words, one of the main questions people have is what does it take for someone's application to actually be seen? Like, I know you guys get a ton of applications. Realistically, how many of those applications are actually seen, like actually observed, and what actually stands out to get someone to that position? If you want to go ahead and start, Dr. Andrabi.
I can start. So we have I don't know if this is a unique process to us or not, but we look at every application. So we don't have
Oh,
at Baylor, we do not have a screening process. Every application gets in front of a faculty to get screened. And that does take a lot of time and commitment from us as the faculty. But I will tell you, we have been able to recruit some amazing residents that way. So we have found like not having cutoffs or things that we kind of use to screen applications. We don't do that. So every application gets read from beginning to end by a faculty member. There's all the APDs, the program directors, and then we have some core faculty who are very engaged in the interview process and who help us screen applications too. We also try to group them a little bit for faculty who are familiar with certain areas. Maybe they came from that area. Maybe they're familiar with the med schools in a certain part of the outside of the country or within the country. So like for the IMGs, we have faculty who are very well versed with the IMG schools and are a little more familiar with them and are able to look through those applications with a little bit of a different lens, which is nice. It's very nice that we have that subject matter expertise, but we look at every application from front to end. Things that I think for us, like, of course, like having SLOEs is important. I think that's something you're going to probably bring up at some point. So those are our language, right, for how we look at clinical skills. But apart from that, I think for us, like service education leadership is really what we look for our residents. Like we really want service-oriented folks, especially because we work in a county setting with a very underserved population. Houston's very diverse, so you're going to be dealing with people from all walks of life. So wanting to recruit folks who are interested in working with that patient population. Of course, education, because at the end of the day, our goal is to make you a board certified emergency medicine physician, and then leadership too. And not only in the department, but also outside of the department. And that's just in a gist what we do for applications.
very cool. Dr. Janik?
Yeah, so I think it's probably not super unique. I think most programs will probably read every application or have faculty look at everything. We do that as well. I think our program is smaller. We probably don't get the same volume that Baylor does, but we also have fewer people doing the work. So one of the APDs or the PD will read through every single application that we get. And we similarly kind of beginning to end, look at all the key factors, look at your personal statement, look at your recommendation letters. And I would say the main things that we're looking for, some of the things that get you looked at more closely is one, that you just have to have the minimum requirements that we consider a complete application. And we do get a lot of applicants, and I would say a lot of international applicants who don't have what we consider a complete application. And so that is one thing to take note of. And what that means is that you have to have your transcript, which most people can have from their medical school. And then you have to have the letter from your medical school, right, in the scene. And then you need a SLOE, at least one letter of recommendation from a residency affiliated emergency department in the United States. So there you can get SLOEs from any emergency physician can fill out one type of SLOE, but then there's a special SLOE that if you have a residency program that you're able to fill out because you're comparing it to your own residents and the other applicants that you see through the application process. So that is what we consider full. And if you don't have a SLOE, then if you have a very impressive application on all the other fields, we will flag you and put you in a bucket and come back and see if that SLOE appears later in the application process. But if it's not there at the beginning, we're not going to like immediately offer you an interview without that complete information. And then the other is like the step scores. If you haven't gotten your step 2 or complex 2, if you haven't put it in there, then we don't know, have you not taken it, or did you fail and you didn't want to share that information? And that is not necessarily a red flag, but we just don't consider that complete information. So we need to know that has been done and passed. And also because if you failed it and you haven't passed it, then you can't start residency. And so we don't want to hire you unless you have completed all the actual requirements to be ready to start. So I would say that's like the main thing that we do. And then the things that we're looking for that kind of put people high on the list for getting interview slots is clinical skills, because we're a very clinically based residency program. So like, how did you do on your SLOEs? What do people feel like, particularly in terms of how you are as a clinician and in your patient care and in your medical knowledge? And then being in Oklahoma, in a place that's not a super international city, we are looking for people to have some reason why they're looking at us in particular. So if you have Oklahoma connections, either you are from here, or you have family here, or you have a particular reason why you want to go there because your couple's matching and your spouse is really looking to like the Oklahoma programs. But like some explanation why you're looking at us in particular, because we also recognize that being in the middle of the country, we are not necessarily on everyone's radar. So we're trying to screen out folks who just apply to literally every program in the country. Because if you're doing that, you probably aren't particularly interested in us, and we'd rather prioritize people that are really wanting to look at us because they feel like they would be a good match. Those, I would say, are the 2 main things that we're looking for when we're trying to see who would get an interview slot.
Understood. Yeah, there was a lot of questions about SLOEs. So if we can just talk about that a little bit. Essentially, what are SLOEs weighted differently? I know there's certain programs, like if you get it from a residency program, it's a lot better than someone that doesn't have a residency program. But aside from that, is there different weighting scales to SLOEs? Is it better to is having 2 better than having 1, or is it much better to have 1 very strong one versus 2 mediocre? Just in general, what would you say about the weighting of SLOEs and how to achieve a SLOE that will actually be impactful? Dr. Andrade, if you can start.
Oh, go ahead.
Oh, I'm sorry.
You want to start? You can start, Dr. Janik. That's fine.
No, it's good. I don't know if we have a pattern going.
Yeah, sorry.
Yeah. So I'll say the quality is more important than quantity for us. We would much rather see a very strong SLOE than several mediocre to weak ones. And that is because that's what we're looking for, right? We want to know that you have gotten to the point where you can do an EM rotation and impress the faculty that you're working with. We see SLOEs from all over the country, because again, we're seeing applicants from all over. And I think we don't necessarily rank certain places as more reliable or better than others. I will say, when we're trying to distinguish, like, what's the difference between a SLOE at this residency program versus this hospital, things that we consider, one is, do we know that hospital? So there are some really big programs that see tons of students every year, and especially some of the big ones in Texas and some of the big ones in Arkansas and some of the other ones in Oklahoma. We see many applicants who have SLOEs from those places. So we're going to naturally be more familiar with those programs. We're going to personally know the faculty at those programs. It's easy for us to call them and ask questions if there are any questions, including Baylor. And so some of this is that there's going to be an inherent familiarity between certain groups and certain programs, just usually by geography. And then I think there's probably clusters. If you're looking for super academic programs, they all know each other. And so there's that. There's just the familiarity in terms of the volume that we see from those programs. And then there are some programs that will give everyone a top third, right? So like one of the rankings that you get is like, amongst all the applicants you have this year, where is this person fit? Are they in the top 10%, top third, middle third, bottom third? And some programs will give top third to 75% of the people that they see that year. And so like we weigh that, right? So like you can get a top third SLOE, but if everybody who went to that program got a top third SLOE, we just take that into account. It doesn't mean that you're not excellent. It just means that's taken into account. Whereas if you get a top 10% and you're the only person that year that hospital gave a top 10% to, then that kind of weighs a little bit differently as well. I'll pause there and see if Dr. Andrade has anything
Yeah,
to add.
I would totally agree with that. And I think after you, like you said, like you read enough SLOEs from enough programs, you get familiar with, okay, like these programs, like only give a handful of people like top 10. or top third. And these programs give a ton more. And you can also tell by the comments. I would also say if you feel like you do your first SLOE and you feel like it's mediocre or you want to do, then it's probably worth getting a second or third. And sometimes we will see that too in the SLOEs. They'll say, oh, this applicant, this was their first EM rotation. And then you can actually see the progress, like in the second rotation that they do, because they take that feedback from their first rotation and they incorporate it. So for me, I also like to see that. So like it's ideally you have a good, strong SLOE, but if for some reason it's mediocre or you're concerned about it, doing a second one and showing how you're able to incorporate that feedback and improve it is also like equally important, if not more important for me to see. Because then I know, okay, this is someone who's like taking that, they're teachable, they're putting it in very quickly and implementing it, and you can see changes from that. So that's the other thing I think I would add too.
Interesting take. Someone just asked right now, what are some specific examples or interactions you have experienced during interviews that left you thinking, wow, I really like that person. We need to try to get them. Can you guys think of any specific interactions?
What a great question. Yeah, I think.
I think for me, so make sure you're very familiar with the programs that you're interviewing at. Make sure you're familiar with their websites. This is maybe the opposite question that you're looking for, but sometimes when applicants ask me stuff that we can find on the website easily or that's available to look up, then it gives me kind of an idea that okay, maybe they're not as interested. They haven't researched the program as well. So but folks who are like, I saw this on your website and I wanted to follow up about XYZ thing or find out more details, then to me, I'm like, okay, they're a little more engaged. They're a little more interested. I think the other thing that's really important, and I know it's tough because now most of these are on Zoom and is the socials. So we get a lot of feedback from our residents. Our residents are very engaged in our interview process. So I would say like some of the specific interactions and examples we get for applicants is from those socials. Like our residents will give us feedback that, yeah, these applicants are engaged. They're asking questions. Like they interacted on the socials. They really genuinely wanted to get to know more about the program. So that's the other place we will get some feedback from them too.
Very interesting.
Yeah, I would second a lot of that. I think having looked at the website and not just asking kind of pat questions. Like obviously if there is like a thing that you really want to make sure you're asking every program, ask that question to every program if there's a particular thing that's important to you. But when you're trying to suss out whether or not a program is a good fit for you, then the questions are going to be more specific and more attuned to what's going on in that actual program. And then I would say also knowing your interviewers, right? So there's usually a little bit of information about the faculty on the websites, and sometimes it's not much. It might be where they're from or what their academic interests are, but it does stand out if an applicant is like, I see that you do social EM, or they even just like the residents last night at the social mentioned that you're the social EM person. Tell me more about what it is that you're working on right now in social EM. Like that kind of stuff stands out because one, faculty love to be flattered by learners who like what they like, right? We do like that. We like people to be like, oh yeah, I'm interested in that too. So don't do it just for flattery, but it also shows that you understand that you're talking to a person who's got their own particular interest and path. And you can learn so much more about a program and about their faculty by getting past all the niceties and really trying to engage with that person as an individual, because you'll be like I learned something about Dr. Janik, really specifically about who she is and what she does, and really like some details about what's going on in that program, which gives you a better image, I think, than how's your PEDS rotations. So I think that's like specific questions that are really like particularly attuned to the people that you're talking to and the program that you're talking to.
I guess to piggyback off that question, do you have any opinion on a med student in particular achieving the balance of building rapport without crossing boundaries, especially with faculty, APDs, PDs, or even just the faculty attendings? Is there anything that you've noticed where you've seen medical students that are doing a bit too much versus showing enough interest while still being able to build rapport? Dr. Janik, would you like to start?
Yeah, sure. That is a really hard line to walk, right? And it's hard to do over Zoom. And there are cultural things that layer onto that. There are gender assumptions that layer onto that, right? In terms of how people are perceived. My general advice is to be, when in doubt, lean towards being professional. You would rather be seen as being really polite and professional than overly casual in most settings. And I think it's probably a little bit different in the resident social side where you want to know that you can hang with these folks, right? But when you're talking to the faculty, better to be to not use overly casual language, do not curse, right? Do not say inappropriate things, be well groomed and well dressed, right? Because part of what that demonstrates is that you can put on the mantle of being a physician and you can talk to a patient as a professional and you can hold that role and that image. And I think it's important to show that how to do that. But when it comes to building rapport in a 15-minute Zoom interview, you're not going to get to people's like deepest core of their selves, right? Like you're just trying to suss out whether or not you jive with someone. And mostly that's going to be on an intellectual level. And so really it's about what you're saying and how you're, and what you're saying it almost is more important than how you're saying it. We can tell when people look nervous and it's okay to be nervous, but try not to be overly casual because then it might come off as uninterested or it might come off as unprofessional.
Yeah, I think I would agree with all that. Like just staying professional, it's hard because you're on Zoom and you don't know this person. So I think just staying a little bit on the professional side and not super formal, like probably not as informal as when you're hanging out with the residents. Most of the interviewers, most of us are also quietly asking ourselves, can I work with this person at 2, 3 a.m. in the morning on a busy shift? And you will see that is actually, for us, that is wording that we see in the SLOE sometimes too, where like they'll write like
Oh.
this applicant passes the 2 a.m. test. And we all know what that means as like faculty. That's part of it. Are they respectful? Are they self-aware? Do they understand like the professional relationship? And part of this is I'm also gauging because in the ED, you're doing this, right? Every day you're going to be working with people that maybe you're not as familiar with, and you have to establish rapport very quickly and get a point across, right? So some of those skills come into play during interviews too.
Very helpful. It's interesting. There was a lot of questions regarding, it was similar to this, but a lot of people wanted to know from the other side when it comes to especially networking. I feel like it's a good time to ask this now. With networking, students want to know from the other side, how do you guys feel? Like when medical students are coming up to you, expressing a lot of interest, trying to get contact, is that seen as a bit too forward? Would you prefer the student make an introduction, then you see them at another networking event? It's okay, now I've seen them before, they met me before, now they can pass my contact. Or is it a good thing? Is it showing that you're very interested in this program, you're very interested in general in emergency medicine, and you just want to establish a relationship with people that are excelling in the program, in the field?
Yeah, I think it's fine. Like, I think networking is so important in general. And for me, I think if I see an applicant and I see, and sometimes we do see them multiple times, right? Because all the different conferences have residency fairs that are set up. I know in Texas, like our Texas like state chapter for one of our EM organizations, like their medical student committee is very active. So they put on meet the program series all the time and different activities all over the state where you can network and meet with programs. So for me, I think it's fine. Like I welcome it a lot of times. I think if you met someone before, it's okay to go up to them and be like, hey, I met you over here. It's really nice to see you again. It helps build that rapport over time. I feel like advice is very low pressure. Like networking is a great way to also get advice on things and not as formal of a setting, which is good. I was able, when I was a student, I found a lot of my mentors through networking as well. So my mentors were not at my med school who were engaged in emergency medicine. And they were the ones who actually helped me get into organized medicine long term. And so those relationships stay over time too. Like when you're after residency, you're applying for jobs, you'll be surprised. Like it's the same players in the field, right? So all of that kind of comes back in this full circle.
Interesting.
Yeah, I'd agree with all that. I think that so if you're talking to like PDs and APDs, it's their job to network with students. And so it's totally fine to come up to us and say who you are and say where you're at in your training process. And if you're interested in applying or think about applying next year or you're in the middle of applying, and that is definitely very much welcome. I think if you talk to faculty who are not educational leaders, you might get different responses because some of them are just like, honestly, just not super into students. So don't be discouraged if that might just be that person. But generally speaking, any faculty that's at a teaching program is going to recognize the importance of getting to know medical students and potential applicants because you are our resource, right? Like you are our future. And so we want to attract good students and we recognize that they come to us in many different ways. So yeah, just engaging with people when it happens organically, it's really great. And I like the idea of organized medicine. This organization, as well as the other big alphabet soup organizations. If there's one that really works well for you or gives you an opportunity to, again, get to know people just as the people and do the work that you all enjoy together, then you stand out and you become somebody that also just knows people, and you can have a relationship that, whether or not you end up in their program, even as you go through residency and then you graduate residency, and then you're all going to be colleagues. And EM is a pretty big family, but it's one big family, and you'll be surprised by how often you see people crossing paths over the years.
Awesome. We got a question here. Someone's asking for IMGs that are looking to secure away SLOEs, e-SLOEs, are there specific months, such as May to September, or application strategies your program prefers for international applicants?
I think for all applicants, I would say like making sure like by the time your application is due in residency cast now, sorry, we're on residency cast. So now that whenever it's due in residency cast, you have your SLOEs done. If they're not, that's okay. That happens too. But that first pass when residency cast opens and we're starting to do our first take at reviewing applications, like if everything is in by that time, that's like the best scenario, right? If for some reason it's not and you get a SLOE like immediately after, just let the program know ASAP, because some of the programs may not know to look back at your application and check and see, oh, okay, their SLOE is in now. So if for some reason it happens after reviews have started, I would just make sure you reach out. But as close as you can get to that time frame, I think is the most helpful.
Yeah, and going back to the whole, sometimes people do multiple rotations, and so you'll have early ones and later ones. I think just being cognizant of like, when are you ready to do a sub-I? When are you ready to do that level of a rotation? And when do you want to maybe do a third-year EM rotation first, if that's an opportunity for you? And if you're going to do a really early sub-I to get a SLOE, we call them SLOEs. If you're going to do a really early one, then maybe have in your plan, like if you can do a second one later, on the chance that maybe you're going to be not the strongest person on the very beginning of that season. That's the only other thing I would consider. But I think in reality, a lot of it really comes down to like when you can get them. And if you happen to be at, like for the applicants we get that who are at med schools that have residencies, it would be weird if they didn't have a SLOE from their own institution. So that is one thing that we will notice. But if you're an IMG, all of your SLOEs are going to be away rotations. And so we understand that as well. And there's a lot of US applicants who don't have EM residencies at their med school, and they have to do aways as well. So just keeping in mind that that's not unusual, that you don't have a home SLOE, and like how people kind of land on the timing is often more dependent on just what's available than, or what their school rules are. Some schools don't let you do EM until a certain time. So there's a lot of stuff that's out of your control, and we recognize that. But I do agree that ideally, if you can get at least one SLOE in by the time the applications open up to us, then it will make sure that you aren't put in the do not look pile because you don't have a complete application.
That makes sense. There was actually quite a few questions about applications. I'll try to jumble them together because I think they're quite related. I think people want to know about residency cast in general. One of the questions is for Okay, so someone wants to know, besides SLOEs, the other letters of recommendation, are those given weight as well for someone's application, or is it mainly just focused on SLOEs? And people want to know about the MSPE and personal statement. I guess in general, like the full application, are there certain parts that are quote unquote ignored, or is it for the most part everything is seen and weighted equally besides the SLOE, of course?
I think so. The SLOEs are important, right? Because that's our gauge into your clinical skills. For the narrative recommendation letters, I will read them if it's from someone I know. Because again, like EM is big, but it's also a small world. So oftentimes we will see narrative letters from folks that we know from other walks of life. So those are always nice to see too, because you have an idea of that individual and kind of the type of caliber of applicant if they're writing a letter for them. So but we'll read them. But again, I don't think we hold the same weight on a narrative letter that we do on a SLOE.
For sure.
Right? Because that the objective data you're getting out of SLOE, you're not getting out of a narrative letter. And I think other specialties are starting to see this too. I've heard of other specialties that are starting to go to similar processes for their application cycles too, of having a standardized letter. But I think in terms of the application, we look at everything. Personal statements are important too. I would say most personal statements are in the middle. Like 90% of them are all in the middle, talking about why you wanted to go into EM. There's usually like a life event that happened or something that triggered your interest in that. I think simple things like just making sure the grammar is correct, the formatting is correct. It can be very obvious if someone uses AI. So just be careful with things like that, especially with AI coming out. I think this past year we've seen that, right? So being cognizant of things like that about it. But we'll also look at your experiences, right? If I'm looking at, for example, in your application, your volunteer activities or your service activities, like if you've done a project over many years that you stuck with, like for me, that is something I look at a lot more highly than you volunteered at one community health fair like for a day, right? So seeing some of that like longitudinal commitment, I think, in any sort of activity or interest that you have on that side is, I think, something else we look at. Sorry, personal statement you asked about, SLOEs you asked about, rec letter, was there anything else?
The
The
MSP.
MSPE.
Oh yeah. And yeah, we look at the MSP too. It gives us a good idea of like how you do on your other, like your transcripts and stuff, gives us an idea of how you do on your other rotations. So we will look at that too. And then your noteworthy characteristics. Most of those noteworthy characteristics, honestly, I think most applicants do a really good job of highlighting that. And now with residency cast, I think on the first page, there's an opportunity where you can bullet out a few different like meaningful experiences. So I have noticed most times those really complement what the noteworthy characteristics are in the MSPE. But yeah, we'll look at those too.
Very interesting.
To that, I would only mostly add, yes, SLOEs count for the most, and the residency-based ones count for the most of that. I would say in general, I don't know how this compares to other specialties. In general, EM definitely has an EM bias. So like we would much rather see a letter from an ER doctor, even a narrative one, than a non-residency SLOE from a non-ER doctor. I don't even know if you can do that. We don't really care what internal medicine thinks of you. That's being a little crass, but like we care much more about what another emergency physician does, because our specialty is weird. Like the way that we practice and the place that we practice and what we do does not overlap a ton with what other specialties do. So it's really hard, we think, for a surgeon to really understand what it takes to do emergency medicine. The exception to that, I would say, is if you have a particular thing that you're interested in that is one of your defining characteristics that is in some way related to what you want to do in EM. For example, if you want to go into critical care medicine and you've done an ICU rotation in med school and you have an ICU doctor that can write a glowing narrative letter about you, that's great. As your third letter of recommendation, right? Have a couple EM ones before that. But something like that to highlight, if you're a public health person and you did an MPH and you're an MPH mentor, can talk about your thesis that you did that is this really interesting thing that like you're going to take that knowledge and move it forward and do stuff in residency with that. Awesome. That sort of thing highlights how you're an interesting individual person. But generally speaking, what we're looking for in the letters is going to be what ER doctors think of you. So I would put that above anything else. Yeah, and then I think we care a lot about what the med school thinks about you. They're hard to decipher depending on the med school, but what it does is it also helps us suss out, depending on your med school, right? So some med schools are really small or really new, and we don't really know a lot about how that med school works and how their grading works and things like that. So there is some data that comes in there about the spread of grades or the distribution of things, and that can give us some information about where you're fitting in that. But probably the most useful thing is the sort of like outstanding characteristics of you, like the sort of defining bullet points. And this goes for the international schools as well. So similarly, so some of those international schools are really big and they churn out a ton of applicants that we see every year, and some of them are small and maybe we haven't seen somebody from that school in a while and we don't really know that school very well. So we will often pay more close attention to those less well-known schools because we're trying to figure out, how does this person fit? Because we can't just be like, oh, they're from Baylor, we know this about them.
Interesting. That's really helpful. I know I'm learning a lot right now. I think a lot of students are messaging me as well, and we're getting a lot of really good info. There is another general consensus of questions that I got, so I'll try to summarize it with this question. Someone's asking, what advice do you have for an IMG applicant who has gap years during their medical school for whatever reason, financial hardship, etc., but wants to pursue EM? So I had a lot of questions regarding similar to this. Some people are asking about gap years in general, how that's seen, and some people are asking whether it's better, for example, if they're coming from a school where they have this awkward year off because of delays during exams, is it better to graduate as late as possible or to graduate early and do something like a research year or something like that? If you guys want to probably tackle both of those in terms of gap years.
I don't think there's like a right or wrong answer in terms of, oh, do I delay it like a whole year or not? I think for me, it's more because there's so many different situations that we see in applications for why people are having to delay their graduation or they're having to take gap years, right? Sometimes, like you mentioned, it could be because they're having to retake an exam. Sometimes it could be because there's a major thing that happened in their family, right? There's a life thing that happened and they've had to take some time away. And so I using the application to explain that, I think is the best way to get that point across. And for me personally, and there's a couple different places in the application where they give you space to put things like that too, to explain any sort of gaps you had or explain certain situations that you want to address that are in your application. And for me, I read those and it's not just about taking that gap, but I think it's like what you've learned from it, right? If it was not doing well on an exam, okay, what did you take away from that? What strategies did you put in place so that didn't happen again? Or if it was a hardship you had and you had to take time away from that, what did that hardship teach you? So I think for me, that's also equally important is like how they respond to whatever the situation is, because we know life happens, right? Like things happen, unfortunately, but it's all about how we respond to them. That's the most important thing. And then I think the other question was about gap years. So again, I think for gap years, if you're taking them for other things, what is that? Is it research? Okay, why research? Like, why did you do that? Is there a particular interest that you had in research? Is this something you're going to pursue long term, right? Some people will take a gap year and do like an MPH or MBA. Some schools have that kind of integrated into their program. Some don't. So is that something you did because you're going to be using that long term in your medical career, right? So to me, it's more not the fact that you just checked a box and did a gap year. It's more like, what did you use that gap year for? And how is that something thoughtful and meaningful to what you want to do with your career as a physician?
Yeah, and I would
Very
just say
helpful.
if you are going to have a chunk of time where you're not in school, you need to be able to explain, you should be doing something that is
Mhm.
like moving towards your career in medicine. Because I will say some people will just like, take off 6 months and go travel. And that sounds really fun. And I would love to do that myself personally. But if you're going to do that, you got to have a pretty good explanation for why you did that instead of hone your skills to be ready to start residency programs, which is it's maybe a little presumptuous on our part, but sometimes that can be a little bit of a red flag of, are you mentally okay? Are you going to be able to handle residency if you just wanted to go chill out and do something recreational for that? So I will say, do make an effort that you're doing something productive. But even if it's like for financial reasons, you have to go get a paying job and you had to do something that is maybe not even peripherally related to medicine, but this is all I could get and I needed a job to pay for my family. That's okay. Because if you've got a good explanation for that, you can tell the story that you are able to work hard, you're able to pivot, you know what's important, you prioritize your family, you are a breadwinner, right? Like you can tell that story and present yourself in that way that shows that's a responsible thing to do. And that's fine. That's not going to come off as a bad thing. That's going to come off as, wow, you've had some challenges and look at you. You've been able to manage that and handle that. So once you get into residency, you're probably not going to be a person that we have to like handhold when challenges come up. We'll be able to know that you're resilient and obviously we'll support you, but we're not gonna worry about whether or not like you can make it through the hardship that is residency, because residency is hard, right? Like it's a lot of work for several years, and we want to make sure that you are up for the challenge of that.
Yeah, I will say it's a job, right? Like
Yeah.
residency is a job. And so people who come into residency who've had jobs in the past, like we see it. It's very obvious to us as faculty. We know the folks who like have had jobs, who've had the responsibility of having to come in, show up out on time, come to work. These things sound simple, in theory, but when it's your first time doing it, sometimes, it's different. It's different than what you're used to as a student. So yeah, I would agree with that as well. And then I think the other thing I just wanted to add briefly was for IMGs in particular, sometimes we do look at like your gap, and if you're applying like a few years later from when you've graduated, like what have you done clinically? Because that's the other thing we'll look at is how far out are you clinically? Like when was the last time you touched a patient and what did that look like? So I think if for the IMGs, because I don't know the spread of folks here, but for the IMGs who have maybe already graduated and they're maybe a few years out, I think starting to think about what have you done in those years where you've done some patient care, right? Because we want to make sure you're not too far removed from that and not losing those skills too.
Absolutely.
Super helpful. Thank you, guys. Just the last few questions here. And by the way, guys, if you guys do have questions, please go ahead and just send them to the Q&A now. But if you would like to directly ask the question, you can just use the raise hand feature and I can just unmute you and you can directly ask question to our panelists. But one question I thought was really interesting. What do you think medical students tend to over-invest time in and stress about with little return, and under-invest time or stress about, which is very important for them?
Good question.
I think, oh, so something simple that I've noticed on rotations when we have folks come through, because when you're a sub-I, you're basically on interview for a month at a program. But I think simple things like knowing ahead of time where the parking lot is, like not being late, showing up on time, doing your research as far as that goes, that stuff, it seems like, oh, it's not a big deal. But I think it makes a big difference on your impression. Your first impression is often your last impression. So just putting in a little bit of extra effort at the beginning of the sub-Is to make sure you are familiar with where do you park, where do you go, where is badging, where is the EM department, which if there's different pods, which pod do I need to show up in? Like all of those things make, I think, a big difference. Is on the rotation side.
Very
Yeah.
true.
I would add to that. I think a lot of students are good at asking for feedback. And then I think it's a skill really to be able to ask for feedback and then to receive it. And also faculty are going to be varied in how good they are and what kind of feedback that they give. So understand you might get different types of feedback. But I think generally as educators, we like seeing students who are interested in getting feedback and who aren't just kind of going through the motions for a month and then hoping that they looked impressive, right? Like if you're on a shift or you've done a couple shifts on your rotation, then touching base with the faculty at the end of the shift and be like, hey, do you have any particular feedback for me? And then the big thing is take that feedback and then respond to it. Because we will notice if we're like, hey, you did not get a very thorough history on half your patients. You really need to make sure you're asking this, this, and this. And then you come in the next shift and you do it, then hey, we notice that. That's the sort of thing where, like to the prior point around subsequent SLOEs, if you're showing that you're teachable, that's a thing that we really like to see, because nobody comes into residency ready to be an emergency physician. That's literally our job, is to put you through that process and get you there. But it is easier for us to do that, and we enjoy it more when it's somebody that we know we can engage in this teaching learning process and we can see you learn. So we're looking for people who are engaged in the education and wanting to do that.
Very interesting. And to piggyback off that, I guess another question that was asked a lot is just in general for students who are doing sub-Is or coming for a clinical rotation, what makes students stand out to you guys or even to residents where residents come to you and they're like, this student's someone that we might want to have. Have you guys noticed any particular characteristics or things that students do?
There's the cultural fit question, which I think is really tricky and hard to do, which is a very subjective kind of thing. So I'm not really sure how to kind of give advice around that, but I think some of that is literally what this match process is supposed to be. Is like you be you and be your genuine self, and we'll try to be our genuine selves. And if there seems to be a fit and we like each other, then that's a good sign of dating, right? But I will say that in terms of what we're looking for on clinical skills of a med student, I think higher level med students are moving towards intern level skills of being able to not only take a good history and do a good exam and do a good presentation about what they learned from their history and exam, but they are able to think through the differential diagnosis of, okay, chest pain. What might this be? 1, it could be a heart attack. 2, it could be an aortic dissection. 3, it could be pneumothorax, whatever. You can say the list. And as you go through that, you're thinking, what do I actually think is likely? And therefore, what is the workup that we're going to do? This is the overall scheme of what a lot of we do in EM is you have this complaint. There's a whole bunch of things that can cause that kind of pain or that kind of complaint. What do I actually think is likely? What are the dangerous things I need to think about and rule out either by story or by testing? And that informs your testing. I don't like hearing people say, let's do a chest pain workup, because that shows to me that you're already thinking algorithmically, which is not what we want. We want you to think, this person in front of me has this kind of presentation, and based off of what I can gather, I think is possibly this and possibly this. And I think we can rule out that just by their description of it. But because it might be one of these two things, we need to do a chest x-ray or we need to do some labs. That sort of thinking, and you're not going to know it all, because to actually be able to do all of that for every chief complaint is really hard and takes 3 to 4 years of residency to do, to get good at, right? That's again what we do in residency. But to show that you are starting that process and you're trying to think in that way is really what we're looking for clinically.
Yeah, I would agree with all that. And then I think I would add, like, also thinking one step ahead now. Okay, once I get that chest x-ray back, if it shows this, then I'm going to do this. If it shows that if it's normal, then I'm going to do this, right? So thinking about that, EM, we're always like dispo. So I try to get that into the sub-Is too, that start thinking about that early on in your process of what that disposition is going to be. I think the other thing is doing what are maybe the not so glamorous, but really high impact things for patient care. So that might be checking vitals on your patient, right? Who needs a recheck because the tech or the nurse is busy, like walking your patients to CT or x-ray, right? To get them that imaging fast. Is it helping reposition patients or cleaning rooms, helping the nurses start IVs? Is it tracking down old records, getting collateral from family? That is so helpful. So many times that the students help us with is like sitting with the family and getting collateral, or calling family and getting collateral, or looking at outside records, trying to keep the nurses in the loop with the plan, to following your labs and images as a student. So as a student, you probably have the least number of patients on your list compared to everybody else on the team. I'll usually tell the students, like, if there's labs or imaging back, I expect you to come up to me and tell me, this is back now. This is what I'm thinking of being the next step now that the CT is back or this lab is back or whatever that is. I feel like that's really golden in EM too.
Really helpful. I think we'll get to these last 2 questions here. So someone wants to know if you and your significant other are applying to EM via couples match and to the same programs, would you as faculty want to know about that before interviews or during interviews?
Yeah, like both applying to EM.
Yes,
Yeah.
to the same programs too. Yeah.
We like to know ahead of time. And largely that is because if you're going to couples match, and we have done this, 2 of our third years are married to each other and they came in as a couples match. So totally happens. And if we like you both, then it's great. It's 2 for us, right? But we want to know about it because if we only interview one of you, then it's very low likelihood that you're going to want to come to us, unless there's another program in the city, like maybe the partner interviews at the other program in town or something. But yeah, it is helpful for us to know, because part of what we're gauging when we interview people who are couples matching in EM or other specialties is whether or not the partner got an interview in town. And this is probably less of an issue in big cities like Houston or on the coasts. But in Tulsa, there's 2 med schools and there's a handful of programs. And so we will ask, if we like you in interviews, we'll be like, if you haven't told us, we're going to ask you, what's your partner applying to and where are they applying? Because we'll call those programs and be like, did you interview the spouse or the boyfriend or the girlfriend? And then that helps all of us know. And then programs talk to each other too, right? If pediatrics loves this couple partner, they'll call us and be like, hey, are you going to interview so-and-so because we really like their partner? And that might bring us to like maybe offer you an interview sooner than we would, and vice versa. So yes, we'd love to know about that.
Yeah, I would agree with that. We like to see that early on for all the reasons that Dr. Janik mentioned. And we see EM, right? And we see EM and non-EM, and same thing. We'll have other PDs reach out to us sometimes and be like, we interviewed so-and-so's partner for whatever, like ortho residency, their partner's applying to EM. Have you had a chance to look at your application? And vice versa. If we interview someone in EM and their partner is applying for EM or applying for another specialty, we may reach out to the other specialty too. We do that a lot. And Houston, we're very lucky because we have a lot of programs. It's a little bit easier. You have a little bit of options if you're applying couples match, regardless if it's EM or if it's EM in another specialty.
So very helpful. And just the last question here. I got quite a few iterations of this question. Essentially, people want to know, particularly for IMGs, the step two score, is there a range they should be going for, or in general, how important is that for their application? And then to piggyback off that, people want to know for IMGs in general for the application, the area that they choose, that they say, oh, I'm interested in this area. Does that carry as much weight as US MDs? Is it as important, or is it not really seen upon the same way? Those two questions, iterations of those questions were asked a lot. If you guys have any thoughts on that.
To the regionality thing, it matters a lot for us because, as I mentioned, Oklahoma is not a part of the country where most Americans think about moving to if they're not from here. And so it is appealing to us if you have a reason for wanting to come to Oklahoma. We're a small state. There's only 3 million people in the state of Oklahoma. It's a big, wide, spread out kind of place. And yeah, so if you have a particular, like, you should be honest. If you really do have a reason for being a part of a particular region or go to a particular program, yeah, you should tell them what that is. So I'd say we carry a fair amount of weight on the signaling side of things.
Yeah.
What was the other question?
Oh, it's step two scores.
Oh, step two. Go ahead, Dr.
Oh, I was just going to say for the signaling, same thing. Like, just you can put ties, and it can be, we'll see ties that say we have ties to Texas because XYZ, or some people are even more specific. They'll be like, I have ties to Houston because my partner's family lives there. And there's a portion of the application where you can list that out. And we do take that into account because as much as you love applying to our programs, you want to hear more about us, those personal ties are much more important, right? Like, those are going to be really the things that are going to pull you to certain places, especially when you have a support system around you. So we weigh that really heavily because then we're like, okay, this applicant is really serious, right? Like, they're applying to our program, but they have a support system here. This is a place they're familiar with. It's a place they want to come back to. So
I would add to that too, though, like, you can signal a program even if you don't have family there or you don't know people there, right? So if you're like, I love Baylor because I love the service oriented thing, and that is me, and that is like totally my personality, and like I'm looking for programs that do that, and I put you on my list because that's what I'm looking for, that's cool too. Like, you can explain that is your reason why you wanted to signal them. And that, I think, for us, that weighs just as much as I like Oklahoma. We get plenty of applicants who apply to us because of the rural thing. And they're like, I want to work in rural Montana. And there's only so many places that really emphasize rurality in their training. And so, like, I'm looking at all the places that do that. So that signals for us seriousness as well. And then as for step two, there's not a cutoff score for us except pass, really. We do pay attention if you have failed any of your steps. That is something that we will signal. And when we see that, we look for an explanation of why did that happen? And then to the prior points, like, what did you do with that? Did you grow? Did you learn to make sure that you are passing your exams going forward? Because you're not done with tests when you come to residency, you still have to pass the boards. And that's one of the metrics that residencies have on, are we doing a good enough job educating people, is, are all of our graduates passing the boards in the first try? We really care about that. So if you're not a great test taker and you struggle to pass the steps, then you might struggle to pass the boards. That doesn't mean you won't be able to do it, but it just signals to us that's the sort of thing that, like, we need to make sure we're paying attention to and getting you to be able to pass those tests. So there's not really a cutoff number, and it's moving to pass fail anyway. And so I think as we go forward, when people have pass fail step two, then we're going to be looking even more at SLOEs and grades and GPAs if they exist, although those are also getting less common, because we're looking for objective data if we can find it in the mix of all this subjective stuff that we're using to try and figure out who you are as a person.
Of course.
Yeah.
Perfect. Sorry, guys, just a bunch of other questions here. I think we'll leave it here for our guests. Thank you guys so much for taking the time out of your schedule. This was super beneficial. I know a lot of people benefited. I know a lot of people learned a lot. Really appreciate having both of you on board. Thank you, Dr. Andrabi. Thank you, Dr. Janik, as well.
Thank you. Thank you, Dr. Andrabi.
thank you guys.
Thank you guys so much. Thank you to all the attendees. Thank you guys so much for logging in. Again, if you guys have any questions about IM, I'll put the link for AAEM RSA on the chat, and you can look into it. And thank you guys so much for sending your questions and tuning in. And our panelists, thank you guys. This was a great event, and I hope everyone has a great day. Thank you so much.